plexus injury case. Well, as the introduction of the faculty comes to a conclusion, I would take the liberty of proceeding with my topic today, which happens to be an approach to the a short case of peripheral nerve injury, which every postgraduate student must practice to present in the examination after learning how to examine it correctly. Well, being a short case, you will agree with me that the time at hand in the examination is barely 10 minutes. And in these 10 minutes, you have to do a lot of groundwork to be able to present your nerve injury case adequately. So we always insist that history should not be very elaborate as far as a short case is concerned, but I have listed these 4 points as the most pertinent questions to be asked in history, or to elicit history on these 4 points. So the first and foremost is, like in all other upper extremity cases, is the dominant hand involved or is it the non-dominant one? Because we all know that the functional demands of the dominant hand are far greater than the non-dominant one. When did the injury occur? So this gives us the time elapsed since injury, because again, one of the most important factors for the final outcome of a peripheral nerve repair surgery is the injury to reconstruction or repair time. As the time increases, the chances of an optimal result are declining. Next is, how did the injury occur? Meaning thereby, what was the mechanism of injury? And we will soon come to what is the importance of this. And last but not the least, what treatment has been given till now. Remember, majority of the patients presenting to our public hospitals, which are usually the centers for postgraduate examination, in these centers, our patients usually come to us on a delayed basis, sometimes weeks, sometimes months later, and some sort of a treatment may have been accorded, which may be in the form of a simple skin suturing after debridement without repairing the nerve, or it may be in some sort of a splintage which has been provided to prevent contractures, and one needs to know what has happened to this patient since the time of injury. Mechanism of injury is important to know because it determines the type, management, and prognosis of nerve injury. To give you an example, the traction type of injuries, which are typically seen in the high-speed motorcycle accidents, where a patient or the rider, when he falls, the head strikes against the curb or the road, and there is a sudden increase in the neck shoulder angle, which causes a traction type of an insult on the underlying brachial plexus. And different components of the brachial plexus may undergo a varying force of traction, and thereby some portions may be completely torn, whereas the others may suffer a lesion in continuity, something like a neuropraxia or an axanotomesis. And that is why this sort of an injury has been labeled as a type 5 injury, or type 6 injury of Mackinnon and Dillon. Contusion is a blunt force creating a nerve injury, typically seen in a closed fracture of the shaft of the humerus, which on deflection of the fractured fragments can hit the neighboring radial nerve, and it can cause an injury. But these injuries are typically recovering type of lesions. Given a sufficient period of time, spontaneous recovery is known to occur. So therefore, When you are dealing with a closed fracture of the shaft of the humerus with the radial nerve palsy, never offer in the examination exploration and repair as the first option. Always it is better to wait for recovery to occur spontaneously, and how it is calculated will again realize during the course of the lecture. Compression neuropathies are self-explanatory, typically seen in carpal tunnel syndrome, where the median nerve is compressed, or Guyon's canal, where the ulnar nerve is compressed, or the cubital tunnel, where the ulnar nerve may be compressed. So these injuries usually are partial type of injuries. They can recover on their own if tackled on an early area or on an early basis, simply by releasing the compression. Lastly, we have laceration, which leaves a clear cut line of action. A glass cut injury on the wrist, creating a median or a combined median and ulnar nerve deficit complete in the hand, is nothing but a neurotraumatic injury, a complete disruption of the injury. And unless you repair this injury or repair the nerve, no recovery is going to occur. So I repeat, mechanism determines the type, management, and prognosis of nerve injury. As far as the examination is concerned, I feel in the case of a peripheral nerve injury case, the postgraduate student or the surgeon needs to act like a detective. He, as per the classical recommendations in a short case, you have to inspect, you have to palpate, but we call it look, feel, and move. So the detective work which the postgraduate student is supposed to do is ultimately leading to the fact that at the end of the examination, when he is presenting the case, he has to have a clear-cut decision on what is the nerve which is involved. Is it a high or a low nerve injury? Is it complete or incomplete? In Seddon's classification, where does it fit in? Is it a neuropraxia, axonotmesis, or neurotomesis? Is it a recovering lesion or a non-recovering lesion? And last but not the least, how will you manage this patient? Meaning thereby, what investigations you will offer and what is the treatment which would be most suited in this situation. The caveat here is that this is a one-time examination. In OPD follow-ups, you have the benefit of seeing the patient of a peripheral nerve injury coming to you on a monthly basis, and that timely or repeated examination gives you a lot of benefit because it gives you an idea whether the patient is recovering or not. So this one-time examination can be tricky, but if you know the nuances of this examination, you will be able to decide all these listed factors which are most important for a peripheral nerve injury case. Well, as far as how to decide which is the nerve involved, well, as having been an examiner for quite a few years, I've always taken care to keep a simple single nerve injury case in the exam, because we do not want to confuse the candidate in the exam, but you may get multiple nerve injury case also. But here we will start, or we will talk to you about what happens or how you select the nerve which is involved. Well, the site of injury is important to note. Identify the attitude. Some injuries have a typical attitude, like the foot drop in a lower extremity sciatic nerve or a common peroneal nerve injury. And based on these two factors, the site and the attitude, you get a clue. You get a clue to what are the specific tests to be performed in this likely nerve injury. And obviously, an exhaustive neurological examination concerning both the motor power assessment and the sensory assessment have to be performed. before you can pinpoint which nerve is involved. To give you an example, this young man presented to us with a blade wire injury 6 months ago, and the treatment which was already, according to him, was a simple debridement and stitching at the primary center that he built. So it's a V-shaped incision mark, healed probably primarily, and he has a typical attitude which we call as a wrist drop. And it is the left non-dominant hand of this patient which is involved, and the attitude does not give us a very, very conclusive clue. So we asked the patient to try and dorsiflex, and he was unable to dorsiflex, and at the same time he is unable to open the digits in extension also. So there is a loss of active wrist and digital extension. And if you look at the typical location of this, it is on the outer aspect at the junction of the proximal 2/3 and distal 1/3 of the arm here. The only nerve which is lying in this area is the radial nerve. The other two nerves, the median and the ulnar nerve, are no way here. They are on the medial side. So this has to be, this gives you a clue that it is a radial nerve involvement. And is it high or low? That is the next question. And in all nerve injuries, to decipher between high and low, first and foremost is the site. If the site is at the elbow or above the elbow, then usually it is known as a high injury. And if it is below the elbow, maybe at the wrist, it is known as a low injury. Apart from the site, there is some sort of an index musculature which needs to be checked. And the index musculature in this particular case happens to be the Brachial Radialis. And we always tell the candidate, first test on the normal side. So if you have to test the Brachial Radialis on the normal side, you ask the patient to hold the forearm in mid-prone position, elbow flexed to almost 90 degrees, and the examiner should apply some sort of a resistance at the wrist level. And this is how the test is performed. And you can see the bulge of the Brachial Radialis beautifully seen on the normal side. And after the normal side, you go on to the affected side, perform the same maneuver. And what you find that there is no contraction. There is no contraction. And once you find that there is no contraction, it is always better. And it is always better to palpate the belly somewhere here to be able to say that there is no contraction, and only then you can say that the Brachial Radialis is MRC grade 0. So there is no motor contraction here. And next in the line here, well, just to tell you, as far as the median nerve and the ulnar nerve are concerned, if it is a high median nerve injury, the typical attitude would be pointing index finger. I'm sure Dr. Kotwal will elaborate on it, but just to give you a bird's eye view, as far as the ulnar nerve is concerned, we have the typical ulnar claw, which is less prominent in the high lesion than the low lesion because of the phenomenon of ulnar nerve paradox. Well, we move on to decide whether it is a complete or an incomplete lesion. Well, a complete lesion means that all the muscles supplied distal to the site of injury are paralyzed. So we need to test the other wrist extensors now, and on actively asking the patient to try and dorsiflex the wrist, what happens is there is a semblance of, if you look at it again, in the initial phase, there is a flexion of the digits, and it is followed by slight amount of extension at the wrist. Please watch this. Watch this happening. So there is an initial jerk at the wrist in the direction of dorsiflexion. Please do not get carried away by this as sign of activity in the wrist extensors. This is a trick movement. which is triggered by the tenodesis effect of the flexor group of muscles, and they create a passive sort of an extension of the wrist, and this should be detected as a trick movement. And if you want to confirm, always palpate the muscle belly at this level, proximal forearm level, to be able to say that there is no contraction. The dictum here is analysis of movement is not analysis of muscle power. You must remember this. And to complete the muscles supplied by the radial nerve, the next in line is the extensor pollicis longus, and the patient is unable to extend the thumb, but he's trying to move it sideways in an attempt to some sort of a trick movement he's trying to do. So extensor pollicis longus is also paralyzed in this case. And last but not the least, the extensor digitorum communis and the extensor indicis proprius need to be tested. And here the hand is passively held in dorsiflexion, again to avoid the tenodesis effect, which may cause some sort of a trick extension of the digits. So this is how the patient is asked to actively extend the digits. He is unable to do. Neurological examination would be incomplete without doing a sensory examination. And since this is a radial nerve case, the sensory supply is in the first web space dorsal aspect. Always compare with the normal side. If you ask the patient by just testing on the affected side, dorsal aspect, he will always say, yes, he can feel, because by the visual effect also, he does volunteer that he can feel. But the moment you compare with the identical area on the normal side, he will always tell you, though he can feel, there is a large amount of difference between the magnitude of the two feelings, and there is definitely a decreased feeling on the affected side. Well, where does this lesion fit in as far as the Seddon classification is concerned? 6 months down the line, there is no contraction in the brachial radialis. There is an incised wound at the outer aspect of the arm. This can only be due to a neurotraumatic lesion. Can only be a neurotraumatic lesion. Neuropraxia and axonotmesis are out of question in this particular patient. And it is also pertinent to remember or revise again that closed fractures anywhere in the body usually cause lesions in continuity, predominantly neuropraxia or axonotmesis, and open fractures have the propensity to cause neurotraumatic lesions. So in this particular patient, there was no fracture. It was an open injury caused by a sharp blade wire. So we labeled it as a neurotomesis. Is it recovering or not recovering? Well, we must remember that neuropraxia and axonotmesis, though they have recovery potential, but the recovery profile is absolutely different. As far as the neuropraxia is concerned, these lesions usually recover within 6 weeks, sometimes within hours, sometimes within days, but definitely within 6 weeks' time. And the beautiful thing is here that there is a simultaneous recovery in all groups of muscles. Whereas recovery in axonotmesis is long drawn, and the proximal muscle supplied by the nerve after the site of injury is the first to recover, followed by the next in line, and so on. And this is known as the phenomenon of motor march, which is proceeding proximal to distal in line. Well, neurotomesis does not have the ability to recover on its own, and it will only recover if a repair is performed, and then it will follow the recovery pattern as in axonotmesis, like the phenomenon of motor march. As far as the phenomena following nerve injury are concerned, The moment there is a transection of the nerve, the distal segment of the nerve undergoes Wallerian degeneration, which is essentially removal of debris. It is a scavenging phenomenon which occurs in the first month following injury. And thereafter, if there is a lesion in continuity or a repair has been done, an epineural repair has been performed, the axonal sprouting will occur at the rate of 1 millimeter per day. And this is what is responsible for a sign known as the Tinnell sign, which has the ability to monitor sensory recovery. It is monitoring only sensory recovery. You percuss the nerve along the course of the nerve from distal to proximal. And at one particular point, if the patient tells you that there's an electric current-like sensation progressing distally into the sensory distribution of the nerve, then that is the point where Tinnell sign is positive. And this positive Tinnell sign, when examined 1 month later on follow-up, should have moved by about an inch. So if it is progressing at that rate, there is a satisfactory recovery occurring. And this should be in tandem with the motor recovery. And how do we monitor the motor recovery? This is as per recommendation of the Seddon, where he explained in a fracture of the shaft of the humerus by drawing this diagram that you calculate the distance between the probable site of injury or fracture till the site of sensory innervation or motor innervation of the brachial radialis muscle. So if this distance happens to be about 16 centimeters, then it is going to be 160 days, because recovery is occurring at the rate of 1 millimeter per day. And do not remember to add 30 days or 1 month of Wallerian degeneration to this calculation of 160 days, because during Wallerian degeneration, no recovery occurs. Well, what was the diagnosis in the case which I demonstrated to you? So it was a high radial nerve injury. And on questioning, when the examiner questions you, is it a complete or incomplete? It is a complete one. It is a neurotomatic lesion as per Seddon. And there are, in spite of 6 months having elapsed, since there is no recovery in the brachial radialis, it is a non-recovering lesion. And it is affecting the non-dominant hand. So as far as the management of this scenario is concerned, it is nothing else but you need to explore and repair the radial nerve and try to either repair it or put a nerve graft, whatever the given situation is. Well, this patient came to the OPD and he just showed his hand and he said that there has been a progressive weakness with paresthesia in the little finger and the ring finger over the last 1 year. The deformity is on the ulnar side, it is gradually increasing, and on questioning him, he said he has sustained no recent injury. Well, looking at the hand, there is intermetacarpal wasting, which is probably due to the dorsal interosseous wasting. The first web space on the dorsal aspect is severely wasted, signifying wasting of the first dorsal interosseous as well as the adductor pollicis muscle hair. And there is some semblance of a ulnar-sided claw deformity. Well, on looking at the sensory part, there was a sensory deficit in the little finger and half of the ring finger, ulnar half, and all the tests of ulnar nerve paralysis, like the Froment sign, the card test, were positive. So a diagnosis of an ulnar nerve injury was made, but we needed to identify what is the cause, and the various causes which came to our mind were, is it a Guyon's canal compression because there is no injury? Are we dealing with a Hansen's disease, or is it a thoracic outlet syndrome? And here comes a very important lesson to the candidate. Never examine the hand in isolation and always insist on proximal limb exposure and examination. So in this case, it was mandatory to palpate the nerve behind the medial epicondyle. So when we just lifted the sleeve, what we found was there is a cubitus valgus deformity. It was a cubitus valgus deformity, and on closer questioning, it was revealed by the parent of the child, of this man. He said that my parents told me I had some injury in the elbow when I was 4 years old. So this made us examine the lateral aspect of this elbow, and we found that there was the lateral condyle was mobile, there was a crepitus, there was a varus and valgus instability, and on the X-ray revealed that there was a non-union of the lateral condyle with a cubitus valgus deformity. And this became, the diagnosis just became crystal clear that we are dealing with nothing else. It's not Hansen's, though the ulnar nerve was thickened behind the medial epicondyle, but it was a tardy ulnar nerve paralysis. And the treatment here is anterior transposition of the ulnar nerve. And on exploration, you can see the normal ulnar nerve, the thickened ulnar nerve due to the recurrent microtrauma creating fibrotic response. And this is how it was transposed, preserving the branch to the flexor carpi ulnaris, which was weak in this particular patient. Well, similarly, a median nerve injury can present with a wasting of the thenar muscles, inability of the hand or the thumb to abduct at right angles to the plane of the palm, as is seen in the normal hand. The left is the normal hand, the dominant right hand was the affected hand. And along with this, there is demonstrable paralysis of the thenar muscles. But one must keep in mind the possibility of anomalous innervation from the ulnar side. And some of these patients, in spite of having a glass cut injury at the wrist, are able to have some sort of a apposition or satisfactory apposition. So one needs to be aware of the anomalous innervation in hand. And obviously the sensory supply of the hand by the median nerve is very important because it supplies the pinch area of the hand. Well, this is a test, Beak test, which is a screening test. This is usually a test where you are not suspecting a nerve injury, but you want to quickly rule out all the three nerves being intact. So this test, by virtue of the fact that the patient is able to dorsiflex the wrist here, the radial nerve is intact. The flexion of the metacarpophalangeal joint, extension of the interphalangeal joint tells you that the ulnar nerve is intact, and apposition of the thumb tells you that the median nerve function is intact. So this is beak as the beak of a bird. Well, we talked about investigations, and we have electrodiagnostic studies which cannot be covered in total in this sort of a program, but you need to know that predominantly there are two modalities. One, the nerve conduction velocity, where sensory and motor velocity both are tested. And the second one is a standard needle insertion EMG, where we should know that the candidate needs to know that a biphasic and triphasic action potentials are normal. They suggest normal innervated muscle. Fibrillation potentials are typically seen in a denervated muscle, and polyphasic action potentials are the ones which are seen or which indicate a re-innervation by a recovering nerve paralysis. The flip side is that electrodiagnosis do not have the ability to decipher axonotmesis, which is the lesion in continuity, can recover on its own from neurotmesis, which will require repair. So that is the drawback, but it does help predominantly in recognition of the nerve injury and detection of recovery and monitoring its progress. How do we treat nerve injuries? If you're suspecting a lesion in continuity, just wait and watch at the rate of 1 millimeter per day, expect progression, and keep on doing muscle testing of the proximal most muscle supplied by that nerve at monthly intervals. If you're suspecting a neurotmesis, explore and repair. In the waiting period, if you are waiting for recovery after repair, or If you are suspecting an axonautomatic lesion and you are waiting for recovery to occur, you need to provide some sort of a splintage to prevent any fixed deformity from developing. If the sensory area is important, as in the median and the ulnar nerve, avoid thermal and mechanical injury. The hand needs to be protected, and mobilization of the supple just to keep the joints supple. And last but not the least, galvanic stimulation, because neuromuscular junction tends to degenerate if it is not stimulated. And this is the most important interface between the nerve and the muscle. And if this is degenerated, even a recovered nerve will not be able to produce function in the muscle. Depending on the nerve repair timing, it can be primary if it is performed within the first 24 hours, typically done in clean incised wounds. It may be a delayed primary done between 8 and 14 days, and secondary if it is done anytime after 2 weeks. The important point to be remembered is that since majority of our patients present late, remember that if a patient is presenting to you after 1 year broadly, especially if it happens to be a high injury, then motor recovery should not be promised to this patient. However, for the purposes of sensory recovery, especially in the median nerve situation, even repair can be done up to or after 2 years, simply for sensory recovery being also important. Well, to show you a case here, glass cut injury at the wrist, 3 months old patient, 3 months old injury. There was a loss of opponent's function, wasting of the thenar muscles, and loss of sensation in the radial 3.5 digits. The injury was detected, and there was a fibrous tissue formation between the proximal and the distal ends. The ends were freshened, and funicular appearance was first identified, and only then an epineurial end-to-end suturing was performed with the wrist in flexion. And this patient had a good functional recovery in due course of time. Well, all patients may not be so lucky, as a gunshot injury patient who presented to us as with the inability to extend the digits, though he could extend the wrist. So it was diagnosed as a posterior interosseous nerve paralysis. Since we were expecting a neurotematic lesion, we explored and we found that after resection of neuroma and glioma, there was only a 1 inch gap, but this gap could not be overcome by any means because the nerve divides distally into several branches like a chorda equina, and the branching nerve becomes less mobile. So the sural nerve can be harvested in such situations, as the gold standard of overcoming gaps today is a nerve graft surgery, and this is placed as multiple strands across the gap, and this is known therefore as a cable graft, just like the 3 wires in a cable in the household wiring. And since the distance to be traveled here was small, this patient within 4 months had recovery of digital extension as well as thumb extension. Well, once recovery starts, you need to see to it, or while you're waiting for recovery, we have already talked about galvanic stimulation of paralyzed muscles, but you must remember that once muscle starts getting innervated, muscle strengthening exercises need to be reinstituted. And when sensation starts coming back, sensory re-education is another very important area which needs to be performed by the occupational therapist. The patient has to be taught all over again what is hot, what is cold, what is blunt, what is sharp, and so on. So sensory re-education is equally important in these patients. What to expect after a nerve repair surgery? Well, this is dependent on several factors. First and foremost, what is the type of nerve which has been repaired? Is it a purely motor or sensory nerve, or it is a mixed nerve? If it is a mixed nerve, there is always a chance of motor to sensory and sensory to motor anastomosis due to a sort of a rotational malalignment, and result is likely to be suboptimal. Whereas a pure motor nerve, like the radial nerve, would have a better result than the median nerve or the ulnar nerve. Level of injury, the more distal the level of injury, the better the motor as well as the sensory recovery. Initial wound condition. If the wound condition on day one was a clean incised wound, primary repair was possible, the chances of recovery or the quality of recovery is likely to be much better. On the other hand, if the wound was contaminated, there was a lot of devitalized tissue, one had to debride and just do skin suturing, and the wound was fit enough for nerve exploration only a month later, then obviously the result is going to be suboptimal. Last but not the least, age of the patient. Children have tremendous regenerative ability, and apart from that, since the limbs are still growing, the size of the patient is small, the distance to be traveled by regenerating axons is smaller than in an adult, and along with that, neural plasticity in the brain provides the child patient with almost normal results after a well-done peripheral nerve repair. Last example, a digital nerve cut just at the base of the index finger and a simple epineural suturing performed. It is a pure sensory nerve, distance to be traveled is small, and this within 3 months, the patient has good sensory recovery in these patients. With the best of techniques of nerve repair available, there will always be some failures, or there will be those lesions which are irreparable. You explore a lesion and you find that it is irreparable because there is extensive damage to a segment of the nerve, and you will have to put on very, very large graft, maybe in excess of about 10 centimeters. And in these cases, you can decide to straight away go in for what is known as a reconstructive procedure in the form of tendon transfer procedures. Well, postgraduate students, I want to leave you with this, a favorite painting, a slide of a painting, which shows Hippocrates relying on the art of palpation and clinical diagnosis to diagnose what is wrong with this patient. And this is what you should be able to practice, the art of clinically diagnosing orthopedic diseases and especially peripheral nerve injuries, and not rely on sophisticated investigations which can be misleading at times. Thank you very much, and 3 cheers for Delhi Orthopedic Association.
Thank you, Dr. Dhal. Dr. Kotwal, you can be ready with your presentation. Dr. Dhal, can you stop screen share? There is a question from the audience. Can I ask you, sir?
Yes, sure.
When to plan for nerve repair and when to go for tendon transfer, any duration?
Well, the answer lies in customization. Actually, you can never have a cookbook type of a recipe, but the dictum is that if your patient is presenting within reasonable time and you feel that a neurotemesis is the lesion which needs a repair, if the injury is less than 1 year's time, especially if it is a low lesion, one should try to repair the nerve in the first instance, because it is said that if the muscles are re-innervated, one gets an independent control of individual muscles, which is not possible with any type of tendon transfer. So tendon transfers should be kept as a sort of a salvage procedure in those cases where a nerve repair surgery either is not possible or it has failed. I think this would have been a reasonable answer to the person who has asked it.
Thank you, sir. And any other question from the panelists?
Dr. Dhawan, can I ask a question?
Yes,
sure.
Sir, Dr. Dhal, excellent, exhaustive talk. My question is, in a relatively recent injury, suppose patient presents at 4 to 6 weeks of injury,
Yes.
Besides history, do we have any method to find out the what kind of, is it a continuity injury or is it discontinuity injury, axonatomesis or neurotomesis at that stage, and or what advice we give to the patient to wait for till some feature appears, or we go immediately and do something?
We have recently been using high frequency ultrasonography for sort of detecting the lesion in these nerves. And this is most successful for nerves which are not very deep seated. So we have not had very good results with the sciatic nerve, but as far as the median nerve and the ulnar nerve, especially in the forearm and the wrist is concerned, the ultrasonologists are able to pinpoint whether we are dealing with a neurotomesis type of a situation, or at times, is it a lesion in continuity? Is it a sort of a neuroma in continuity? And the accuracy has been to the extent that when we have compared the site which was declared in centimeters by the ultrasonologist, it almost matches with the surgical exposure. So high frequency ultrasound is another very important tool which has recently come into the armamentarium of the orthopedic surgeon, and it should be exploited. MR neurography is also available, but you need very, very sophisticated and expensive coils. Every MR center will not have those coils. These coils are highly dedicated for MR neurography, and only then you can have a good idea of what is happening to the nerve. So I think ultrasonography is a better option in these scenarios.
So do you think it should be a protocol? Suppose a patient comes with a recent injury, that you go for an ultrasound and depend your decision on that?
I would, you see, I was in an academic setup, so it was a learning experience. There was a thesis going on. So every case we were subjecting it to ultrasonography. But I personally feel if you are in a private setup and you want to keep the expense to the patient low, then you can reserve these investigations only for those patients where there is a doubt. You see, a glass cut injury, for example, at the wrist, does not need an ultrasonography to say that it is a neurotomesis. If there is a complete cessation of conduction beyond the wrist, say for the median nerve, there is complete motor paralysis, there is sensory loss, I think there is no need for any investigation here. You can straight away at 4 to 6 weeks time, as the patient presents, go in for an exploration, and you will almost always find a transaction type of injury.
Dr. Dhal, there is another question from the audience.
Yes,
what should
please.
be done in case of radial nerve palsy during close reduction of humerus shaft fracture and casting? Should we explore or wait?
Very good. I think this question has been asked, which is very important because we are living in a world where everything has to be fixed today by surgical techniques. And but it is so interesting that in my entire career, if there has been a fresh fracture of the shaft of the humerus with a radial nerve paralysis in a close fracture scenario, I have never operated on this patient. I have treated the fracture by closed methods, and I've treated the nerve injury also by an expectant attitude. And I have found that the humerus fracture unites by conservative method, and even if the nerve does not recover 6 months, 7 months later, if you have to explore the nerve, at least you do not have to do anything for the shaft of the humerus. So this is, I think, since it is rare to find a neurotomesis type of injury with a close fracture, and the protocols of management are designed on generalizations and not rarities, I think the standard dictum should be treat both the fracture as well as the radial nerve injury by conservative methods.
Sir, I think another concern is if it occurs while doing the reduction or while applying the plaster, then patient develops the palsy, then do what?
Well, Holstein and Lewis was the group which described this type of injury. But over the last decade or two, there have been other investigators who have and the number of cases in Holstein and Lewis series was just 6 to 7 patients, and he had operated on all. Whereas larger series are now suggesting that even Holstein and Lewis fractures can be treated conservatively, and even post-reduction palsies can be treated conservatively initially, and majority of them recover. Well, this is a gray zone. This is clearly a gray zone, and here there is a divided opinion even in standard textbooks. If you look at Campbell's orthopedics or Green's orthopedics, there is a division, and the authors of the chapter have said that in our experience, we would like to operate upon a secondary palsy. If after reduction of the shaft of the humerus, there is a palsy occurring, they would like to operate. But as I said, there is literature available today to support a conservative treatment also. And when you operate, you obviously fix the fracture first, and then you identify what the lesion is. If the nerve is caught between the fracture, you release it. If it is damaged, you would like to repair it.
Dr. Dhal, there is another question. Which investigation is better, NCV or EMG? Which can be done first?
Well, when you send the patient to an electrophysiologist, it is a standard dictum that both have to be done. Both have to be done because each one of them is giving a different type of an information, and it is the subtotal of the information which is then analyzed, and then a report is formed. But it is quite obvious that if you are dealing with a compression neuropathy, if you're dealing with a carpal tunnel syndrome type of a situation, here nerve conduction velocity, both motor and sensory, are important. And majority of these cases in the initial phase, sensory nerve conduction velocity may be normal. So, and EMG has the capability of telling you whether the muscle is getting paralyzed or not. So abductor pollicis brevis, EMG is equally important. So I think rather than saying which one is more important, it is, I would say, both have to be done, and you have to look at what is happening to that data and how it is to be correlated with the clinical situation. Only then you can make a complete interpretation of the same. So both are equally important.
Okay, Dr. Dhal, we will basically allow Dr. Kotwal, and we'll take questions later on. Over to Vineet Dibbas to invite Dr. Kotwal. Dr. Vineet, are you back?
Yeah, I would like to invite Dr. Kotwal to start with his talk. Please take over.
Okay. Thank you. Good afternoon, everybody. I would like to thank the organizers of the Delhi Orthopedic Association, and specifically Dr. Sharad Agrawal, Dr. Manish Dhawan, and Professor Anil Dhal for giving me an opportunity to participate in this seminar and the webinar and talk on the injuries. Again, the important the ulnar and the medial nerve injuries. It's not going forward. Something problem. Can you see my, okay, right. Of course, actually, I often say that when more than one people speak on the same topic, there is bound to be repetition. So number one, bear with it. And particularly, it is also an advantageous for this for the postgraduates, because there will be some repetition, which is actually would be important for them. And Dr. Dhal has the excellent lecture that he has given has made things easy for me. So I can certainly skip some of my slides, which actually he has already talked about. So these are the causes of nerve injury. However, I would also like to mention, and he has also done that the compression neuropathy is also one of the causes. Actually, it's not exactly injury, but the patient will have definitely pain and maybe at times paralysis of that particular nerve. In the diagnosis, it is important to know the site of the injury. There are susceptible sites like the nerves close to a bone. At the ulnar nerve, you have the and the ulnar nerve at the elbow and the radial nerve in the arm. He has shown a very beautiful case on that. Then there are closed spaces, particularly the carpal tunnel, which will have the carpal tunnel syndrome. And then the structures of the adjacent ones, like the median nerve is close to the brachial artery. So if there is an injury of the brachial artery, then you can also suspect that the patient may be having an injury to the nerve as well. And also the order you should know in which the branches are given by a particular nerve as it traverses from the proximal to the distal. So that would give you an idea as to what nerve must be paralyzed and how to test for it. In the diagnosis, there are certain things like he has said, look, feel, and move. So in the look, you have to have the look for the site of the scar, if there is any one. Then the trophic ulcers, the skin, whether there is smoothness or dryness of the skin, and whether there are any circulatory changes or temperature changes in that particular extremity distal to the injury. On inspection, you can also see that there are, particularly sometimes there are tapering of the fingertips due to the loss of the subcutaneous tissue. So this is also an important finding actually in the diagnosis of a nerve injury. Then the characteristic postures. Radial nerve, you already seen, will lead to a wrist drop, and the ulnar nerve injury will lead to a claw hand. So here the diagnosis is actually, it's a spot diagnosis. Then the characteristics postures, you also have a median nerve, you will have a vesting of the thinner muscles and an adducted thumb. So it's called as an ape thumb. Whereas there is a combined median and ulnar nerve palsy. That means you are seeing here there is vesting of the thinner and the hypothinner muscle as well. And then there is to look at the adducted thumb. And so this actually is called as a simian hand. The alteration of the contour. You can see here there is definitely the muscle mass between the tendons is gone, it's atrophied. So this is actually because of the vesting of the intraossei in an ulnar nerve injury, and this is the loss of muscle bulk. So because of which what happens that the bones appear prominent, because the bones which are normally masked by the muscle mass, that the muscle mass is atrophied, so the bones look more prominent. In the motor assessment, one must test all the major muscles supplied by the particular nerve in the limb. The selective muscles testing should not be done. And for example, in the median nerve, you should be able to test all these major muscles, pronator teres, flexor carpi radialis, pronator quadratus, and so on and so forth. So that will actually give you the localization as to what is the level of the injury, if at all, that the patient has. So testing for the pronator teres, what you need to do is the elbow should be in 30 degree of flexion, and ask the patient to pronate, and you resist the pronation. So the muscle that becomes prominent here is the pronator teres. So this is how you can test the integrity of the pronator teres. The another muscle supplied by the median nerve is the pronator quadratus. So what you do is you ask the patient to completely flex the elbow and then ask him to pronate. And this pronation is being done by the pronator quadratus, because here now, because of the flexion of the elbow, the muscle, the pronator teres, has been knocked off. Then there are these various tests, the pen test, by which they are testing the integrity of the abductor pollicis brevis. Then you have the pointing index finger test, because there is paralysis of both the flexors here supplied with the median. Now the patient will not be able to flex it completely. Then you test for the flexor pollicis longus and the flexor carpi radialis. And this against resistance, when the patient is asked to flex their wrist, you can feel or see the muscle if it is intact. Otherwise, the patient will not be able to do that. The opposition, also the patient is asked to do the movement of opposition, and if there is a median nerve paralysis, he will not be able to do that. And you can also see this is of course a patient with leprosy, but you can see there is so much of vesting of the thinner muscles, and the patient is not able to perform the movement of opposition. Then you test the actions of the flexor digitorum superficialis and the flexor digitorum profundus. And here, this is the way it should be done. When you are testing for the action of the profundus, the action, the PIP, the MP joint and the PIP joint, they should be kept in extended. Then only you will allow the FDP to act. This is the Bunnell's O sign. The patient is asked to make an O on both sides, and this he is able to do it on the normal side, whereas on the affected side, he is not able to make this O. And this is because the paralysis of the anterior interosseous nerve, which is a branch of the median nerve given in the forearm. And this happens because there is paralysis of the anterior interosseous nerve leading to loss of the FPL and FDP. So the FPL and FDP. So the patient is not able to make a O. So this is called as a Bunnell's O sign. In the ulnar nerve, you would test the flexor carpi ulnaris and resisted flexion at the wrist with little ulnar deviation. They will make the FCU tendon stand out. And if there is a paralyzed thing, you will not be able to do that. Another test for testing the FCU is you ask the patient to squeeze them. And you can see here, there are some, on one hand, the wrinkles are more, whereas in the other hand, the wrinkles are a little less. And this happens because of the paralysis of the flexor carpi ulnaris. The patient is not able to flex it completely to get a full grip of his hand. And therefore, he is not able to squeeze it. So therefore, the wrinkles which appear in this are actually proportionate to the power that he has because of the flexor carpi ulnaris. Then in the ulnar, you test for the integrity of the intraossei by doing the CAR test. And also you can test the first dorsal intraossei by doing the abduction of individual fingers. There are a few more tests which are again done to test for the intraossei muscles, whether they are paralyzed or not. You ask the patient to cross the finger. So he's trying to bring it on this side and take it on the other side as well. And this actually he will not be able to do, like he's not able to do it here because of the paralysis of the intraossei. You know that the palmar intraossei and the dorsal intraossei, they do the adduction and abduction respectively. So you may not remember the names of this thing. It is not essential for you to remember the names. You just must know the basic principle of the test, that the patient, you ask the patient to move the middle finger on either side. And this he will not be able to do on an affected side because there is paralysis of the adductor intraossei. The cone test, you ask the patient to make a cone of the fingers, then this he will not be able to do on the affected side due to paralysis of the adductor pollicis muscle. So he is not able to bring those together. The testing of the abductor digiti minimi, and you can ask by applying force to the action of the abductor digiti minimi. This you will be able to do if there is intact. But otherwise, in a paralyzed hand, this thing loses the control on the little finger because of the paralysis of the abductor digiti minimi. So what happens is that because of the unopposed pull of the extensor tendon, the little finger goes into a little abduction and hyperextension. So you will not have a control over the little finger. This is again because of the paralysis of the abductor digiti minimi muscle. Then the paralysis of the flexor pollicis brevis actually will not be able to make a good key pinch, and as a result of which the thumb will go into hyperextension and this grip will be weak. So this is again the test for the integrity of the ulnar nerve. The paralysis of the intraossei and hypothenar muscles, there will be loss of lateral movement of the little finger. He will not be able to actively bring the little finger onto the outer side. So these are the various tests. Basically, they are meant to test the intrinsics of the muscles of the hand. Then this is a very common test. You all know this. You ask the patient to hold a book and you try to snatch it away from him. And this is how he will hold it on the normal side, but on the affected side, he will try to hold it by flexing the IP joint of the thumb. And this is because there is paralysis of the adductor pollicis here. And therefore, he is bringing the action of flexor pollicis longus. He is employing the flexor pollicis longus to hold the book. And this is called as book test, and this sign is called as Froment sign. So there are two different things, don't confuse. The test is called as a book test, and the sign is called as a Froment sign. The classical spot diagnosis thing is about the claw hand in the cases of ulnar nerve injury. And the loss of the intrinsic function causes the clawing of the fourth and the fifth digits. And this is a very classical example of clawing of the hand. And generally, what happens is that the clawing can be corrected if the MP joint is stabilized. Because as it goes into hyperextension, if you stabilize the hyperextension at the MP joint by adding neutral or slight flexion, the deformity gets corrected. And this is basically the principle of most of the surgical procedures done for correction of the claw hand. So what you do is, in surgery for the correction of the claw hand, by various procedures, you will try to stabilize the MP joint in neutral or in slightly flexed position, which will correct the claw of the hand. And this actually, this can be tested, and this maneuver or test is called as Boovius maneuver. So what you do is you try with your finger, you try to stabilize it in the slight flexion, and the extensors, the extensor tendons, they will extend it, the digit completely, and the deformity gets corrected. This is an important maneuver because it tests the integrity of the extensor mechanism. It helps in choosing the correct surgical procedure for the correction of the claw hand. If the test is positive, that means if it gets corrected, you can definitely go ahead and do a surgical procedure with good results. But if it is negative, that means it doesn't get corrected by doing that maneuver. That means there is some insufficiency of the extensor mechanism, and it would require some augmentation, and either the problem may be either flexor tendon shortening or maybe the joint contracture. And this is how you can see if the principle is followed properly, the clawing can be corrected by any surgical procedure. So in the examination, you would test the movements at the joints with the help of a goniometer, and you can also test the strength in the hand muscles and also in the pinch as well. There is a pinch gauge available for that. Then the sensory, you all know the sensations they are supplied in the hand by the various nerves. And in the pinprick sensation, if it is absent, it suggests that there is a dense sensory loss. And if it is present, then one must do the testing for the soft touch test for the sensations. The touch can be moving. The testing of the touch can be done. It can be moving or constant. And this is how you do it. For the moving touch, you use the spin wheel. And for the constant touch, you have this testing of the 2-point discrimination. This distance you can increase, and with the patient closed his eyes, you try to ask him that whether he is feeling 2 pricks or he is feeling 1 single prick. For the receptor system in the nerves, there are 2 types of receptor systems, the quickly adapting fibers and the slowly adapting nerve fibers. The quick adapting fibers, they are responsible for the moving touch, whereas the slowly adapting are responsible for the constant touch. And this is how the difference is, that the 2-point discrimination is less in the pulp of the finger. So that means the distance here is only, the patient can feel 2 distinct pinpoints at a distance of 5 to 8 millimeter, whereas as you go more proximal, the distance is more. So this 2-point discrimination depends upon the quickly adapting nerve fibers, and this returns early as compared to the slowly adapting fibers. Then Dr. Dhal talked about the Tinnell sign. The rate of growth is 1 millimeter per day. Just a little more detail about the Tinnell sign. As the time progresses and you are seeing the progression of the nerve recovery, then you test it. So the Tinnell sign, if it is less at the time of injury and increasing distally, that means there is a good chance of useful recovery. That means the nerve is regenerating and progressing distally. If there is a strong Tinnell sign and also an increasing Tinnell sign distally, paresthesia distally, that means there is some poor chance of recovery because there is some neurons are still there which are getting converted into a neuroma. And on the third scenario can be that there is a strong Tinnell at the injury site, but none distally. That means there is no chance of recovery, and one must go ahead and explore or intervene. The investigations have already been talked about by this thing. I will only show you this newer investigation, that is the neuroma. This is the MR, actually neuroma. This is MRI, and it's also called as neurogram, neuro MRI also. So what you do is, and this you can see here, this is the proximal cut. It is showing the nerve here. Then this is the distal cut. It is showing the nerve here, but there is no nerve seen here in the middle of the limb or forearm. So that suggests that there is definitely loss of continuity of the nerve, and this helps you to take a decision. So when to operate? Initially, there is voluntary degeneration, and then the electrical activity starts only between 2 to 4 weeks, and therefore the electrodiagnostic studies should only be done after 3 weeks. It is never reply that soon after the injury you will do an EMG or an NCV. It will be pointless. Then this has already been talked about, the various types of nerve injuries. The neuropraxia, these are the examples, the Saturday night palsy or the crutch palsy. Exonotmosis would be associated with fracture, and neurotmesis is a stab injury or a gunshot injury. So the neuropraxia is generally muscle atrophy is rare, and it will conservative treatment is all that will suffice, and usually full recovery occurs in about 1 to 4 months. However, if there is any doubt or delay, one can go ahead and explore and do a neurotmesis. This also has been talked about. Generally, the neurotmesis or the exonotmesis, they would require, at least particularly the neurotmesis will definitely require surgery. One has to observe for the exonotmesis. The indications would be nerve known to be divided but not repaired, obviously will require surgery, and fractures with open wound will require treatment for both the fractures as well as the nerve. This has also been talked about by Dr. Dhal, when is the timing for the nerve repair. And in old injuries, you do repeated examinations. You look for this sign, Tinnell sign, whether it is, which scenario it is, whether it is progressing or not. And the EMG will also, and then if there is a painful neuroma, then obviously you have to go ahead and operate. So what surgery will you advise? It can be in the form of either neurolysis, neuroraphy, or nerve repair, and nerve grafting. And here is an example of a neurolysis. This is the hand, that's the thumb side. You can see here the vesting of the thinner muscles, and the nerve was the median nerve explored. You can see here, this is the proximal end. The nerve is more or less normal, is rather normal here. It was must have been the cut injury, the sign of earlier cut injury. And you can see here, there is so much of fibrosis surrounding the nerve. So all you need to, and perhaps there appears as if it is the nerve is in continuity. So once after exploration, if it is intact, you only need to do neurolysis, and the patient would have recovery after some time. In the nerve repair, the best is to do an end-to-end repair whenever possible, but never under tension. If you see a scenario like this, an old injury, that's the nerve, and you have a neuroma there, then it is essential that you excise the neuroma till you get the neural tissues, and then do a nerve repair or do a nerve graft, as the case may be. What are the types of nerve repair? It can be epineural. Dr. Dhal has shown some beautiful examples about that. So you just repair the epineurium. Then it can be the fascicular repair, which can be in the groups. The fascicles can be repaired in groups, or it can be repaired in individually, fascicular repair or the funicular repair, as it is called as. And the suture that we use is very fine 9/0 or 10/0 nylon. And of course, it requires magnification. You can't do without it. Here is an example of a digital nerve that is being cut here along with the tendon. These are the two tendons, the superficialis and the dip, FDP rather, to the little finger. And that's the nerve which has been sutured just with an epidural, one stitch on this side and one stitch on that side. That is good enough. And as said by Dr. Dhal earlier, it is a sensory nerve, so it will have a good prognosis. The nerve repair can also be facilitated by mobilizing the nerve by doing transposition, as in case of ulnar nerve, when it is injured at behind the elbow, you can bring it anteriorly, you can get more length, flexing the joints, doing bone shortening. And if the gap is more than 2.5 centimeters, never repair it, go ahead and do a graft. So here is an example of a epidural nerve repair. This is the hand, that's the median nerve going into the hand. And this is all fibrosis, and this has been cleared. These are the fascicles of the nerve, branches of the median nerve going into the palm, and this has been repaired by an epidural repair. So this is another example of a neuroma excision and an epidural nerve repair. And this is also fascicular nerve repair. That means the neuroma is excised and the fascicles are separated. So there are 3 fascicles separated here, 1, 2, and 3. and then you will use a nerve graft to bridge the nerve cut ends. So what are the types of nerve grafting that you can do? Trunk graft, cable graft, pedicle graft, interfascicular nerve graft. I showed you an example picture of that, and individual fascicular nerve graft. And there people also use a vascularized or non-vascularized nerve graft as well. Where do you take the nerve from? The sural nerve is the commonest site where you harvest the nerve for grafting. You get a very long segment of nerve. Otherwise, these are the other sites from where you can harvest the nerve. People also use allograft for grafting it, and then the nerve conduits are also used selectively in certain cases. Here is an example. This is the ulnar nerve at the elbow, and that is the cut hand here, and this is the cut hand here with the neuroma here. So this has been cleared up, and this is the sural nerve graft taken without separating the fascicles. They've just been sutured like this. So this is actually a cable graft. So like a cable, you are just attaching them. Whereas this is a fascicular graft. You know, the fascicles are separated, and these are the fascicles separated here, and this is the graft. You can differentiate the junction of the graft with the parent nerve, and the same here as well. Just to wind up about the compression neuropathy, about the median nerve in the forearm. This is the hand side, this is the elbow side, and this is the median nerve that you can see here. And this is the flexor superficialis facial arch, which is actually causing pressure on this, producing the pronator syndrome. And as you release this here, you can see there, this is now decompressed, and you can see the normal diameter of the nerve distally, whereas proximally under the compression here, this is thinned out so much. There was definitely very considerable compression of the nerve in that area. Another example of an ulnar nerve compression neuropathy. This patient had a big lipoma sitting in the Guyon's canal. And these are the ulnar nerve, they are the branching out. And this ulnar nerve was getting stretched over it. So the lipoma was dissected out. And obviously the compression can now be relieved. So to conclude, the nerve injuries are common, often missed. So the clinical diagnosis and electrodiagnostic studies should be done at the correct time. The surgery also should be at right time and choose the correct method for treatment. Nerves should be handled with care in terms of, because you should not give sort of much surgical trauma while handling them. Otherwise, there will be more fibrosis and neuroma formation will occur because of your poor handling of the nerves. So to conclude, the prompt diagnosis, proper treatment can help you get. Hello.
Yes, continue, sir.
Yes, sir, you are audible, sir.
Yeah. Did you see this slide? This is the concluding one.
Yes, sir, it's visible.
Was I audible?
Yeah.
You are audible, sir.
Okay, right. Okay, that's it. Thank you.
Okay, thank you, Dr. Kotwal. At present, there are no questions from the audience. So we can, Dr. Vineet, we can move forward.
Yes, I think.
Yes, sir. Yes, sir.
I would like to invite Dr. Pankaj Jindal for his talk on hand.
Dr. Vineet Arora, you had some question?
Okay, you can continue. No, you can continue, sir.
Okay. We can
I ask a question? Dr.
Yes, sir.
Dr. Kotwal, if you have to choose between epineural repair and the fascicular or the perineural repair, are there different the results, or how do you decide which kind of repair should be done in which situation?
Yeah, actually the best is individual fascicular repair. That's the best one, because then you are actually doing the correct cooptation. That means, because like Dr. Dal also said, in a mixed nerve, there can be cross connection between the sensory component and the motor component. So if otherwise you are trying to do the correct cooptation, the nerve, and then separate out the fascicles and do a fascicle to fascicle repair, that is supposed to give the best results. And for that, you, of course, the thing is, it is little more technically demanding because it definitely requires magnifications. You are separating out, and generally depending upon the level of the nerve, it can have either major 3 fascicles or major 6 fascicles. So that means you will have to repair this thing. But in fresh injuries, and if there is not much of cooptation difficulty, you can even do a epidural repair as well. And particularly in if there is a major cut, for example, if you are doing replantation or multiple nerve injuries, tendon injuries, and if there is a time problem, then obviously you can do an epidural repair as well. But like answering your question, the best is fascicular, and that's why people have also tried to do a vascularized fascicular nerve repair or grafting for that matter, so that, you know, it's supposed to give, like for any vascularized bone grafting or whatever, it's supposed to give better results.
Thank you.
Sir, Dr. Kotwal, Kotwal, can I have a question?
Sure.
Sir, for a fresh, clear-cut injury of the 2 ends of the nerve, what is the best way to repair?
Yeah, like I told you, if it is a fresh, clean-cut wound, you can even do an epidural repair also. The cooptation should be proper. That means, you know, the nerve should not be twisted and all those things. Then you can even do an epidural repair as well, or you can separate out the major fascicles. Even a nerve would have major 2 or 3 fascicles at that level. If you can separate out that and even do that group, that's called as group fascicular repair, that also is generally okay.
Sir.
Dr. Vineet, please call the next speaker.
Yeah, till time Dr. Jindal is sharing his screen.
Yeah, Dr. Kotwal has to take
Yeah, Dr. Kotwal, please unshare your screen.
Okay, okay.
And I think Ravi will have to give permission to Dr. Jindal to share his screen.
Dr. Ravi?
Yeah, in the meantime, I think Dr. Hitesh has a...
Yes, sir.
Yeah, I have a question for Dr. Kotwal, sir. Can I ask?
Yeah.
Yeah, sure.
Sir, in a case with neuroma in continuity, how do you decide operatively to do neurolysis or excise the neuroma and do a formal repair?
Yeah, it's a good question, and at times a difficult decision. What you need to do is, under a little magnification, you dissect out the neuroma, because in continuity means there will be some fascicles which are intact, running normal, and there will be some fascicles which will be injured, and they will lead into a neuroma formation. So what you need to do is you dissect out the fascicles, isolate the neuroma, excise that neuroma, and try to repair that fascicular thing. So therefore that you require, as I said, magnification. The only risk about that is that in the process of dissecting out the fascicles and trying to isolate out the neuroma, you should not be damaging the intact nerve fibers or the fascicles. But this actually would be, the question was how we decide. So there will be some partial signs of nerve injury or something, or maybe as seen by the EMG, some muscles are working, some are not working, something of that kind. So that will also help you take a decision about exploration.
So we used to inject saline operatively that time. Is it helpful?
Sorry?
We used to inject saline proximally and see that saline propagated downwards or not.
These are actually methods described all right, but I don't know this is really that diagnostic, in my opinion.
Can I add a comment here?
Yeah, sure.
These days we are using intraoperative electrical stimulation to be able to decide whether the neuroma in continuity is conducting or not. So you will have to warn the anesthetist well in advance that in this particular patient, we will be using intraoperative stimulation, and therefore they will not be able to give any muscle relaxant. And with that sort of maybe a brachial block or something, you can do an intraoperative stimulation, stimulating the nerve proximal to the neuroma in continuity. And if you find that there are certain muscles distally which are contracting, then you can leave the neuroma, just do a neurolysis. You can do both internal as well as external neurolysis and leave it. And if it is a non-conducting type of neuroma, there is no muscle contraction distal to it. You can resect the neuroma and do an end-to-end repair.
Dr. Vineet, we will take questions later on because we are falling short of time. Dr. Vineet, can we continue?
Okay.
Dr. Pankaj Jindal, can you
Yeah,
hear me?
I'm ready. Can you see my slide?
Yes, sir. Yes, sir.
Yes.
Okay. Thanks the Delhi Orthopedic Association, Professor Manish Dhawan, Dr. Sharad Agrawal, Professor Dhal, for giving me this opportunity. Let's start on a talk on paralytic hand. Okay. We'll be talking about general principles of treatment of a paralytic hand. We'll be touching on intrinsic minus hand, the mechanism which leads to clawing, because that itself can be a short case you might be asked to write, and on the from end sign. To restore a paralytic hand and to reanimate it, you might do a nerve surgery, that is either repair the nerve or you would do a nerve transfer. But this talk is about tendon related surgery. So how you can use tendon transfer to restore paralytic hand back to function. So what is so specific about the paralytic hand? The specific thing is, like in a median nerve injury, there may be loss of opposition. Like in the case of a ulnar nerve injury, you can have a loss of pinch, or in a wrist or in a radial nerve injury, you can have a wrist drop. Or it can go on like a brachial plexus injury, you can have an inability to flex or extend the elbow, or abduct or external rotate the shoulder. So how do you approach a patient with a paralytic hand? You go in for a history and examination. So in the history, you ask whether it's an acute problem or a chronic problem. And if there's a trauma, whether that's a recent trauma or a past trauma. Similarly, there's a history of viral or a fever of recent origin of a past. So like you have a patient with an acute injury in this lockdown period, somebody stabbed this guy and he had a C5, C6 lesion here. So there's an acute injury here. Whereas this boy, which we are going to talk in a little while again, is a chronic injury here. Because as you can see, the skin is scarred and the joints are all stiff. Further, in the physical examination on inspection itself, you can see the mark of injury along the surface anatomy of the nerves. You'll see wasting of the muscles. You can see deformities, which I am again going to repeat. You have a specific test, which like Professor Kotwal has mentioned earlier, or Tinnell sign here. So like you have a patient with a injury on the outer, on the radial, on the lateral aspect of the arm. So you can make on inspection, you have a suspicion in the back of your mind. Probably you have a patient who has a radial nerve injury here. And again, this is along the surface anatomy of the radial nerve, and he is having this kind of a wrist drop here. So see the mark of injury along the surface anatomy and what lies under these scars. Similarly, you have an injury on the back posterior aspect here, and on the injury was here, but small injury on the posterior aspect of the medial malleolus here. There was nothing here. The more important thing was the small tiny cut on the posterior aspect on the ulnar nerve, which was the cause of the distal deficit here. Similarly, like you have this injuries here, you have this wasting here. These wasting suggests there is a problem in the median nerve distribution here. Carpal tunnel syndrome patient here presented with wasting of this hand here. Then you see the deformity here. This was a childhood injury, and there was the non-union of the lateral condyle giving rise to this cubital valgus. And what you see here, inability to adduct the finger here. So this was yet another problem here. So see the deformity here. This was the deformity, clawing of the fingers here. Further, you see the gesture of the patient. The patient is telling you the surface anatomy of a nerve here. Rarely will the patient say, I've got pain in the hand. Patient will say, I have got numbness of the small finger. I have got numbness of the thumb. I have got numbness of the index finger. This finger feels difficult. This finger feels different. See the patient's gesture. What is he pointing at? What is she pointing at? Whether the patient is pointing out on the ulnar side, whether the patient is pointing at the radial side, or the patient is pointing at the far radial side here. The patient is telling you the surface anatomy of the affected nerve here. Or the patient said, I wake up in the middle of the night. I wake up as the hand is gone dead. the patient is telling you, I have got median nerve problem, carpal tunnel syndrome here. There are various tests. I'm not going to go into the details. Professor Kotwal has mentioned to you about the Phelan test, the reverse Phelan test, or the active middle finger flexion test. You flex it against the resistance here, and the patient says, ouch. The patient has got pain here. This is pronator teres syndrome here. Froment sign here, the book test here, or the passive elbow flexion test. As you flex the elbow here, the patient said, I've got tingling in the small finger. So this is for suggesting of ulnar nerve deficit. Again, the Tinnell sign, you tap on the nerve and the patient gets shooting pain down the sensory part of the nerve here. You start from the brachial plexus, go in the supraclavicular, infraclavicular, along the medial side of the arm, into the medial side of the elbow, into the median nerve, into the ulnar nerve here. So you, on Tinnell sign, will again suggest which nerve is getting affected here. Distal to the forearm, you have three nerves here, the median nerve, ulnar nerve, and the radial nerve. But proximal to the forearm, you can go right up to the brachial plexus here. So multiple nerves can be affected proximal to the elbow joint also. You are supposed to know the power of each muscle, and based on the Medical Research Council grading here, 0 to 5, this is extremely important because based on this, you are going to do your tendon surgery here. I'll come back to that in a little while here, but you must know how to grade them based on MRC. Professor Kotwal again made my life easy here. You must identify, because this can be a potential donor here. So test individual muscle. The word is individual muscles. Each muscle has to be tested individually, index, middle, ring, and small. And also Professor Kotwal has published a paper on identification of the palmaris longus here. So identify the palmaris longus also here. So confirm which muscles are paralyzed, which muscles are active and are sparable here. I'll come back to that. So having identified the motor muscles which are affected or not affected, you come to the sensation here. The sensation is varying according to the cause of the imbalance here. Like in polio, the sensation is normal. In Hansen and leprosy, the sensation is absent. Whereas in peripheral nerve lesion, like you have a cut in the forearm, depending on the level, it may be variably affected here. Similarly, in syringomalia, the sensation is partly affected here. Now let's talk further the physiological basis of tendon surgery in a paralytic hand here. Now, the muscles are active and they are controlled at the brain level, at the conscious level or a subconscious level, at a conscious level or at a subconscious level. Like this child, the child is learning to balance very consciously. He might trip a little, quite a few times here, bruise himself, but most of his activities to start with a conscious level. But as he goes further and further, these become some subconscious level, and balancing is subconscious, pedaling is subconscious, from left to right, from left to right, from left to right. He keeps doing, and this is a repeated activity. It is this repeated activity that what happens with this activity happening repeatedly, it becomes a pattern. And what is this pattern? This pattern is what is called as a synergy. This is synergistic or working together. So certain movements become synergistic. And what is this synergistic movement? The wrist extension and finger flexion, and this is happening at a subconscious level. So let's dilate with these two things again. So what are these synergistic actions? Wrist extension is happening together with finger flexion. These are synergistic action here. Similarly, wrist flexion and finger extension are synergistic action, and they're happening subconsciously, subconscious level here, and they do not require significant effort in happening together here. Whereas there are other actions which can also happen, which are non-synergistic action, like extension of the finger and extension of the wrist are non-synergistic action. Similarly, flexion of the finger and flexion of the wrist are non-synergistic action. And what is the applied importance of this synergy? In treating paralytic hand by tendon transfer, the first choice should be a tendon whose muscles are normally synergistic with the paralyzed muscles, and therefore choose synergistic muscle as the first choice here. The next thing that you need to know about the agonist and the antagonist here when it comes to the joint movement here. This is the normal lie of the fingers here, which means if the patient is flexing the fingers, the corresponding extensors are relaxing. So there are one agonistic which are working and a corresponding agonistic are relaxing. So these two things are working together. But if the agonist is paralyzed, the antagonist is unopposed. If it is unopposed and is remaining unopposed, it develops what is called as now a stiffness here. So when agonist is paralyzed, antagonist is unopposed, in due course this becomes permanent and becomes stiff unless you are doing passive range of motion here. So remember, passive range of motion is important so that you prevent stiffness from setting in here. A classical example is a claw hand here. A classical example means the lumbricals and interossei are lying anterior to the MP joint and dorsal to the PIP joint here. So if they get paralyzed, this interossei lumbricals are paralyzed, they go into reverse posture, that is hyperextension of the MP joint and flexion at the proximal interphalangeal joint. So you get a hyperextension at the MP joint and flexion at the proximal interphalangeal joint. And how it can happen? There are various causes. And what can be the cause? You need to know. A paralytic condition like a Guillain-Barré syndrome, Landry-Guillain-Barré syndrome, spelled as Guillain-Barré syndrome here, or it can be because of a common condition in some parts of the country, leprosy or trauma. So these can be the various causes which can lead to loss of intrinsic function of the hand here. So you need, so to restore function, you need to know certain principles and certain prerequisites for tendon transfer. So what are the principles here? Examine. Examination will consist of two parts, what is lost and what is remaining. So what can be achieved from what is remaining? So this is what is going to donate to what is lost here. So how you can compensate the A that is lost from B, and that is all about tendon transfer that you need to know to start with here. Having examined, then you need to know what is remaining and what are the donor muscles. Are they expendable? Can they be spared? Are they of sufficient power? Sufficient power, we talked of the strength, the grading, grade 0, 1, 2, 3, 4, 5. If they are already 3, you can't use them for motoring the paralyzed muscles. So you should have a good power here and appropriate amplitude. They should be working. They can't be having paralysis here. They should be synergistic. We talk about this, and they should have a appropriate alignment vector. We'll talk about this and perform one function. So you enumerate what is lost, you enumerate what is available, and then what are the usually things which are available? Usual available muscles are the FDS of the ring, FDS of the middle, Brachial Radialis, Palmaris Longus, extensors of the wrist, extensor ulnaris, most often FCR and FCU, and biceps. These are the muscles which are usually available here. So find out what is lost, what is available, and you enumerate them on either side here. And based on which is easily available, which has a good trajectory and has a good vector, which has a good excursion, you match. And suppose this is a case of a radial nerve palsy, you have a loss of wrist extension, finger extension, a loss of thumb extension. You see what is available and you match table 1 to table 2, and you have a good functional hand here. The next thing is the tendon transfer. Tendon transfer basically is an interplay of motor and the root, which basically means if you are at this cross section here, your intersection here, you go north, you reach New Delhi, you go west, you go to Mumbai, and similarly you reach other way depending on the route that you have taken. So if you have a muscle which is attached to the radial side of the MP joint, it becomes an abductor. If the same muscle is transferred to the ulnar side, it rotates the thumb also on the CMC joint, it becomes an opposition. Similarly, the same muscle coming in between the metacarpal, instead of becoming an abductor, it becomes an adductor because it is now pulling the thumb towards the rest of the muscles. So the root is a second important thing that will decide the function you are targeting to. Then the evaluation of the muscle. We talked about the expandability of the muscle, then about the strength of the muscles here. Strength is important because usually a muscle will lose a grade 1 when it is transferred. So it is grade 5, it will become grade 4. It is grade 4, it becomes grade 3, which basically means you cannot choose a muscle which is already grade 3 because grade 2 will be a useless function. So you have to have a muscle which is important, which is strong. Next thing we talked was about the amplitude of the excursion. There are various muscles which have a variable amplitude, Like the wrist extensor have an amplitude of about 33 millimeter, whereas the profundus has an amplitude of 70, which means if you are using wrist extensor to power the finger flexor, you will get only about 50% of the excursion. But you have no other choice, but you have a choice between wrist extensor to finger flexor, and therefore you should warn the patient that you will be getting a 50% function based purely on the tendon transfer. Rest will come somewhere else. We'll talk about that. The next thing about the synergism, we talked about it. Rehabilitation of a muscle whose tendon has been transferred is less difficult when you transfer this synergistic. Therefore, always choose preferably a synergistic muscle here. Then we talked of the vector. The blue car will have a difficulty in maneuvering this curve as compared to the red car here. Similarly, this van, when it makes a straighter curve, it is easier for it to maneuver this curve. And therefore, when you choose a muscle, see to it that it has a vector which is relatively more straight. Otherwise, it changes inadequately, inefficiency sets in, and therefore choose a muscle which has a straighter excursion, which again means dissect out the muscle more proximally so that it reaches the target more efficiently here. So having identified the motor, having identified the route, you have to go into the local requirements, which means the prerequisites of a local tendon transfer here. You have to have a soft, unscarred milieu. I'll deal with it again. The joint should be soft and supple. The joint should be having no deformity. The sensibility should be good, which basically means you restore function in a hand which is insensate. You will burn his hand. He will damage his hand further, and therefore restore sensibility, preferably primarily here. And most important thing is stabilization of the neural recovery. When the patient is still recovering, you do the tendon transfer. It's not worth it because the patient is likely to recover spontaneously, or patient is deteriorating and you do a tendon transfer. You do a muscle which is already affected, which is not affected. You do a tendon transfer, and sooner or later that muscle is also going to get affected. Then it is not worth it. Therefore, the neural recovery or deterioration should stabilize before you take up this patient for surgery. Now let's talk about first 2-3 things here. Can you do anything to this car? You can't set in the engine, right? Because the outside is not good unless the outside is proper, which basically means the outside, that means the skin is damaged here. You can't do any median nerve surgery here. You can't do any flexor tendon surgery because the skin is scarred and it can't have any excursion here unless you do a flap on this patient. So the same patient, the flap has been done before any internal surgery can be done here. Coming to the soft and supple, again, unless the joints are good, you can't do anything to this patient here. So again, this patient had a scarred joints here, and we mobilize these joints with various dynamic splints, and before any deeper surgery can be carried out. Third thing about the correction of the joints here, this patient had bony fusion on the dorsal aspect here, though the rest of the joint was intact. We freed up the joint on the dorsal aspect, interpose so that it does not occur before any surgery can be carried out here. Therefore, again, very important here, the correction of the joint deformity should be set in order before any surgery can be carried out here. Certain nerve transfers may also be useful to restore function of the hand alone or concomitantly, and this has to be considered as well. I'm not going to talk about this right now here. I'm not talking about thumb opposition, and I'm not talking about opposition because there are some other important thing that we need to consider. Low median and ulnar nerve palsy are common, leading to clawing, and this is because of paralysis of the lumbrical intraosseous. What happens here? Lumbricals and intraosseous are lying anterior to the axis of the MP joint and dorsal to the axis of the PIP joint here. So when this muscle is paralyzed, it leads to hyperextension of the MP joint and flexion of the PIP joint. I'll deal with it further, but important to know, we talk about clawing not because that is the only paralytic condition, but because numerous muscles and numerous joints come into play, bringing the biomechanics into play. So there are other conditions also, but this is relatively more complicated, and therefore we talk about this in greater detail here. So what happens when you have a intrinsic paralysis? it leads to two things. One thing is a hyperextension of the metacarpophalangeal joint in a mobile hand. If the hand is stiff, well, it may not really happen. So the cause is hyperextension of the MP joint leading to clawing. And the second thing, there's a lack of power of the flexion of the MP joint, which can be to the extent of more than 50% here. That means 50% of the hand power is lost just because of this deformity here. And therefore, the solution lies in preventing metacarpophalangeal MP joint hyperextension. And the whole treatment revolves around prevention of MP joint hyperextension here. So this is another important thing for postgraduates, pathophysiology of clawing here. Just understand this photograph. This is extremely important. There is no way it can be simplified here. Extensor digitorum communis, the long extensor is working. Now, let me first understand, let me explain you what is this. This is the metacarpal. This is the proximal phalanx. This is the middle phalanx, and this is the distal phalanx here. These two green things are the lumbrical and the interossei here. And this is the extensor of the long extensor of the MP joint here. So when the extensor digitorum communis is working on the MP joint, it causes extension of the metacarpophalangeal joint. As it tightens further, as it contracts further, it tries to extend the PIP joint and the DIP joint also. But there are strong sublimis and profundus working on the PIP and DIP joint. They prevent further extension of the PIP and DIP joint under the effect of EDC here. That basically means if you cut the FDS and FDP, you will be able to extend the PIP and DIP joint. But in real life, you can't cut the flexor tendons. You can do something else. And what is that something else? You flex the wrist. If you flex the wrist, now under the added Teno DC section of the EDC, you will be able to do extension of the PIP joint and the DIP joint. But this leads to inefficiency because the strength of the wrist, the strength of the finger flexor is extended position. And therefore, somehow you have to extend the finger. And the simplest thing, as Professor Kotwal mentioned, is prevent hyperextension of the PIP, hyperextension of the MP joint here. What you do, you make this lax here. So added tightening of the EDC, added excursion of the EDC will be transmitted to the PIP joint and the DIP joint. And now you can extend the PIP joint and the DIP joint. So you prevent the hyperextension of the MP joint to get extension of the PIP joint and the DIP joint. And this is called the Bouvier's test or the Bouvier's maneuver, which basically means here you prevent hyperextension of the MP joint and ask the patient to actively extend the PIP joint. If the patient can do it, that means the extensor tendons are useful and can be used for treatment. Which further means if the patient is not able to extend the PIP joint, that means the central slip has become stretched out and you cannot use this for surgery here. And therefore, this has a clinical implication. If on doing a Bouvier's maneuver, if the intraphalangeal joint do not extend, that means the central slip is stretched out here. This has again the clinical implications. Like when you're doing a lasso procedure, again, I'll come back to that here. If you flex the MP joint here, if the central slip is stretched out, this surgery is not going to work. So what is the effect of intrinsic muscle weakness? Either one thing, it causes hyperextension, and second thing is lack of power. We talked about hyperextension and how to prevent it. And second thing is the loss of power. What happens in a normal situation? MP joint flexes first, followed by PIP joint flexion, and the third thing to flex is the DIP joint. But here it is reversal. It is first that IP joint which flex, and the MP joint happen to flex in the end, which means the finger flexes and closes first, and therefore this leads to loss of power of the MP joint, which is more than 50% here. And this reversal has to be corrected also. So what is the aim of correction of the claw? The aim is very simple: block MP joint hyperextension. And there are various procedures which are available here, which are active and passive. Active is using a tendon transfer. Passive is using not using a tendon, which is either a capsular correction, tendon correction, bone correction, or orthodesis here. Various muscles are available. Which one to use is based on the experience and the opinion of the surgeon here. But the bottom line is target MP joint flexion and PIP joint extension. And the route is always volar to MP joint, because that's the route followed by lumbricals and then interossei, and it is dorsal to PIP joint here. There are various tendon transfers available, various motors are available. We talked about it earlier. It's very important for postgraduates to know all these names. Bunnels, modified Bunnels, Fowlers, Riordan's, Brands, Riordan's, various tendon transfers are available. It's not possible to go into the details because you have to go through them again and again to understand the difference. But bottom line, as I said earlier, is the tendons are going volar to MP joint and dorsal to IP joints. So there are various transfers you are supposed to know here. EF40 is very popular amongst very senior surgeons here, and you may be asked what are these. So you are supposed to know. Does it make a difference? It makes no difference. Ultimately, you want to correct hyperextension of the metacarpophalangeal joint. Then we talked about this lasso procedure here. This, you take the sublimis. There's a pulley which is called as an A1 pulley, which is spanning the metacarpophalangeal joint on the volar aspect. You take out the sublimis tendon and you loop it around the MP joint so that pulley is used around which it is looped, so that the moment you tighten this sublimis tendon, it will flex the MP joint, which means you are preventing the hyperextension of the metacarpophalangeal joint, and this is called as a Zancoli's lasso procedure here. When the tendons are not available, you do a passive procedure, which means you cut a part of the capsule of the MP joint here and you tighten this. This capsulodesis. Similarly, you have tenodesis here. Coming to something more, that will be the clawing and the Froment sign. If you have a patient with ulnar nerve palsy or ulnar median palsy, you will have symptoms on the radial side. You'll have symptoms on the ulnar side here. The symptoms on the radial side are because of paralysis of the adductor pollicis, flexor pollicis brevis. I'll come back to that to make it simplify. And third and fourth, interossei. The lumbricals of the index finger and middle finger are working because they are innervated by the median nerve, and therefore index finger and middle finger may not show clawing unless the median nerve is also affected. And we talked about the clawing on the ulnar side, so we'll not talk about it. So let's see what's happening on the radial side here. And this is pinching action. The pulp of the thumb comes in contact with the radial side of the index finger, leading to a pinch here. Now see what's happening here. This is important because you have to understand next 3 slides, because we'll come to why Froment sign comes. Extensor pollicis longus is acting on the IP joint of the thumb. Extensor pollicis brevis is working on the MP joint, and abductor pollicis longus is working at the base at the CMC joint here. Whereas on the radial side of the MP joint, abductor pollicis brevis is coming, a flexor pollicis brevis is coming, and on the ulnar side, adductor pollicis is coming. And the big boss, the big, very active, thick tendon is a flexor pollicis longus, which is coming on the IP joint here. The moment you have a patient with ulnar nerve palsy or ulnar median nerve palsy, the 3 muscles become inactive here. APB is not working, flexor pollicis brevis is not working, adductor pollicis is not working. So you have muscles on the back, you have muscles in the front. Now what happens in the absence of these 3 things? The moment patient tries to flex, the FPL takes the bigger role here, and now it tries to oppose, and therefore you see what is called as now a Froment sign here. So you see a Froment sign, or the book test becomes positive here. And because there is hyperextension at the metacarpophalangeal joint, that is what is called as the Jeans test here. So this is what leads to the Froment sign becoming positive in a patient with ulnar median palsy here. So we talked of radial side symptoms, we talked of ulnar side symptoms. Of course, you can have lesions more proximal. We'll just touch these things here because of brachial plexus injuries here, and the patient will have inability to abduct. So you do either fusion or you do some kind of a tendon transfer, like in a OBPP palsy here. So coming to, in summary, you find out what is lost, what is available, and choose a synergistic muscle choose an appropriate route, and you do a tendon transfer under a good quality skin with a soft joint, provided the patient had good sensation and the patient has stabilized neurologically. The bottom line is you have to prevent the MP joint hyperextension by doing an active tendon transfer. No tendon is available, you are passive procedure here. I am open to question if there is any.
Thank you, sir, for this wonderful talk. And the illustrations are very good, actually.
Dr. Vinay, Dr. Abbas?
Yes, sir.
You can request the next speaker to get ready. And there are a few questions for the audience, from the audience, for Dr. Kotwal. Can I ask them?
I'm the next speaker, sir. I need to start my...
Okay, so there are two, you can start that. There are two questions from audience for Dr. Kotwal. Can I ask that?
Yeah, sure.
Dr. Kotwal, what all tendon transfers to be done for medial nerve palsy, thumb opposition and FDS?
For opposition, opponent's plasty, there are multiple tendons available. And if there is only median nerve paralysis, then you can take the flexor digitorum sublimis from the ring finger and do the opponent's plasty. Sometimes there is paralysis of both median as well as ulnar nerve, and you don't have any tendon available on the volar side. Then on the dorsal side, you can, the most commonly done tendon transfer is the transferring the EIP, extensor indicis proprius, and bringing it there, onto the volar side. So this also can actually work very well. So of course there are many that really cannot be covered up here, but these are the ones which are commonly done: the branch transfer and the EIP transfer.
Okay. And sir, is there why there is loss of thumb abduction in median nerve palsy of abductor pollicis brevis when abductor pollicis longus is still working, which is supplied by radial nerve?
See the flexor pollicis longus. You are talking about the median nerve paralysis. Sorry, can you repeat the question?
Why there is loss of thumb abduction in median nerve palsy of abductor pollicis brevis when abductor pollicis longus is still working, which is supplied by radial nerve?
Yeah, agreed. But the main powerful muscle is the abductor pollicis brevis, which actually causes the thumb abduction. And even in all operations of opponent's plasty, when you insert the transfer tendon, you duplicate the action of abductor pollicis brevis. So you insert it into that. So that is the most powerful muscle. The abductor pollicis, yeah. I think Pankaj wants to intervene.
If you can see my face, abductor pollicis longus is abduction in the plane of the hand. Plane of the hand, abductor pollicis longus, where opposition is at right angle. So there's a big difference. It's a palmar abduction. This is radial abduction, and this is a palmar abduction. So palmar abduction initiates. The word is initiate the act of opposition. So there are big difference, 90 degrees. Am I right, Professor Kotwal?
Yes, yes. It does. It can only help. It cannot cause complete abduction.
It initiate. That's initiate.
Yes, it can initiate. I was about coming to that. It can only initiate. It cannot actually cause that.
Okay. Dr. Hitesh had a question. This is the last question, Dr. Hitesh. You want to ask?
I will ask later. I will ask after this.
Okay, talk. Dr. Vineet, you can please continue.
Am I audible, sir?
Yes, sir. Yes, sir.
Yeah. So this talk for the next 15 minutes, I wanted to focus mostly on things that a postgraduate is expected to know in his exam when he's dealing with a patient with radial nerve paralysis. This is just to complete the slide. I'm not going to dwell into the anatomy a lot. This is purely a theoretical topic, and I would encourage the postgraduates to revise their anatomy. All I want to mention here is that the radial nerve in the spiral groove on the posterior aspect of the arm is the most common site where the radial nerve is injured. Like any other nerve, it can be injured at anywhere along its course. It can be compressed by various causes, but this is the most common site. And then on the anterolateral aspect of the elbow, and when it passes on to the forearm, that is the other more common site where it gets injured. This Dr. Dhal has already covered, and it makes my life easy that we need to know the muscles that are supplied by the nerve, but we also need to remember the order in which they are supplied. This helps us in delineating the level of injury when it is not obvious. It may be a double level injury in certain patients. It may not be an obvious cause and we are looking for a cause. So by doing a muscle charting, we are able to have a gross idea where the nerve is injured. Plus, I would like to, at this stage, bring about this classification of a very high radial nerve paralysis. These injuries are usually in the axilla, which is proximal to the branches of the triceps, supplying the triceps, and the triceps is paralyzed. It's a rare scenario where radial nerve is paralyzed, but which is distal to the brachial plexus, but proximal to the triceps branches. So practically, we don't see these patients very often. High radial nerve paralysis will be typically have a normal elbow extension, but they will have wrist drop and they will have paralysis of the finger extensors and the thumb extensors. Low radial nerve paralysis, as Dr. Dhal has already mentioned, the brachial radialis is considered an important muscle to delineate between high and low. But as per the Campbell's orthopedics and my understanding, the low radial nerve paralysis will be where the wrist extension is still possible. That means at least one of the wrist extensors is still functional. So in this case, wrist extension would be there, but there will be no extension at the metacarpal phalangeal joints and extension of the thumb. Typically, these patients will have a radial deviation while they are extending the wrist. Coming to the common causes before I go into the examination, we all know one of the most common scenarios is a fracture shaft humerus where the radial nerve is paralyzed. Most of these cases in closed injuries have neuropraxia, and Dr. Dhal has already discussed the management, so I'm not going to dwell into too much. The open fracture is one particular situation where we expect a higher incidence of nerve transactions. And I usually would recommend that as a part of the debridement of the open wound, the nerve should be explored. And if it is found cut, either repaired or at least tagged so that it can be repaired at the earliest. This is another common cause where this is one of the cases where the humerus shaft was plated elsewhere. The patient had a radial nerve injury. It was found lacerated. It was tagged by the surgeon there as they did not have the full facility for nerve repair. And I explored this again and did the nerve repair. This is another scenario on the anterolateral aspect just proximal to the elbow or in the posterior aspect of the arm where a sharp laceration leads to radial nerve injury. And we have already talked about principles of nerve repair, so I won't dwell into it again. Other common causes, post-operative, while approaching the humerus from the posterior aspect, even from the anterolateral aspect, it is not that the nerve cannot be injured. One has to be careful, even when they are going from the anterior or anterolateral aspect, that it can be injured if we are not careful. Saturday night palsy and crutch paralysis, these are usually because of compression. Saturday night palsy typically would happen in an inebriated patient or a patient in deep sleep where the arm is over the edge of a hard surface and they get up in the morning and there is a wrist drop. Luckily, these have very good prognosis and they recover on their own. Post-injection paralysis, again, luckily we are seeing less and less. They behave differently. They don't follow these Seddon's classification. They don't typically follow the pattern of neuropraxia or exonertomesis. And missile injuries can happen anywhere along the course of the radial nerve. And it's a topic in itself. I won't again dwell into the management or the prognosis of this injury. Coming straight forward to what I feel is important for a postgraduate student while examining this is examination of a patient with radial nerve paralysis. Typically while examining this patient, I would divide my examination into three parts. One would be the site of injury, the local examination at the site. If there is a fracture, whether it is healed or not healed, are there any wounds? Are there any surgical scar? How is the soft tissue condition? Is there any sign of infection? Is there any sinuses? And so on and so forth. Then I will proceed into the motor examination. Motor examination typically will have wasting of the forearm. This is a low motor type injury, which will have wasting of the forearm muscles in the posterior compartment of the forearm, and a typical deformity of wrist drop, which Dr. Hull has already shown. This is just a repetition of the same thing. Wrist drop, no active extension. By stabilizing, it is difficult to examine the metacarpal phalangeal joint extension in this position. It's already visible that MCP are in extension because of the wrist flexion and the tenodesis effect of the extensors. So it is important to stabilize the wrist in extension while we are testing for MCP extension and testing for the EDC. At this stage, I'll again mention the importance of examining the palmaris longus because it will be useful in tendon transfer, which we'll discuss later. The sensory component of the radial nerve, typically it is described by various authors that it is not so important. It's a very small area. The autonomic zone is very small area on the dorsum of the first rib space. At times it may not be very well delineated, and clinically this is a non-contact area of the hand, and for all practical purpose, the radial nerve is considered to be a motor nerve. The motor function is what we are mainly concerned with in radial nerves. Muscle testing, we'll start with triceps. Not to miss out that muscle testing or any other examination will also include examination of the other nerves to be sure that we are dealing with the isolated radial nerve paralysis. Please do not go with the idea that we straight away start hitting on the radial nerve and this is all we have to examine. The examination should be complete with examination of the other nerves, vascular examination, and like in any other short case. The muscles typically which are important for examination in a radial nerve paralysis: triceps, brachial radialis. Dr. Dhal has shown a very beautiful slide of examining a brachial radialis. I'll again show the slide. ECRB, ECRL would be wrist extension and radial elevation. Here, some of the examiners may ask about how to differentiate between ECRB and ECRL power. It's a very difficult, one cannot be absolutely sure, but one can flex the elbow and test for wrist extension, and that would be ECRB. And with the wrist extended, ECRL would become effective. For all practical purpose, these are muscles which are closely supplied by the radial nerve, and in practically in most of the cases, they will be paralyzed together. So we may not be asked whether we want to test them separately or not. EDC, extension at the metacarpal phalangeal joints. I've already shown the slide how to do that. ECU would be wrist extension and ulnar deviation. EPL is one of the easiest muscles here because it is a pure action, a single joint, extension at the IP joint. No other muscle is causing that extension. However, I would warn the student that in some patients, because of insertion of the abductor pollicis brevis and adductor pollicis on the extensor expansion of the thumb, the patient may give slight extension at the thumb, just like that, but they would not go through the full range of motion. One has to be careful that this is not action of the EPL. If that happens, that is because of insertion of the abductor pollicis brevis into the extensor expansion of the thumb. APL and EPB is thumbs up, as Dr. Jindal has beautifully explained. In the palm of the thumb, we ask the patient to extend the thumb and see for the function of these muscles. Brachial radialis being important, Dr. Dhal has explained the importance. It tells us whether it is a high or low radial nerve paralysis. Also, the most common site being in the arm. This would be the first muscle to recover. So if in a fracture shaft humerus patient, I want to see if the nerve is recovering or not, every time the patient visits me, I would look at the brachial radialis. If it starts recovering, then I'm comfortable that the motor march has started. This being mostly a motor nerve, the Tinnell sign may not be very evident. So this becomes very important. The motor power of brachial radialis is difficult to ascertain. We can look at the contraction of the muscle while asking the patient to flex the elbow with the forearm in mid-prone position. Trick movements, I'll show a video. Tenodesis effect, Dr. Dhal has already shown. I'll just show a video on my own hand, having seen these patients, how the movement happens. And extension of the IP joints can be misread as extension of the fingers, and one has to be careful while examining this patient. Extension of the IP joints will happen in a patient with radial nerve paralysis because of the intrinsics being intact. The student, from my point of view, needs to be aware of this concept of apparent weakness of ulnar nerve in radial nerve paralysis. With the MCP joint in flexion, not stabilized in extension, the intrinsic muscles are slack. And due to that, the abduction and adduction cannot happen. So while examining the ulnar nerve in these patients, I would stabilize the MCP joint in extension and then ask the patient to adduct and abduct. If we don't know this fact, we may also label this patient as having a ulnar nerve weakness. So quickly going through the video, this is the tenodesis effect. with the extensors being stretched using the finger flexion, the patient is able to raise the wrist, but not beyond the neutral. He'll hardly bring it to the neutral. So I'll ask the patient to raise the wrist with either the fingers extended or the fingers flexed, not allowing him to do that while raising the wrist, and look for the contraction of the muscle. This is the other trick movement where the IP joint are extending. The things become more difficult when there is a plaster splint extending the MCP joint or a cock-up splint which is poorly applied. And as you can see, this is giving an impression of extension of the fingers. Like Dr. Jindal was explaining, we need to know what is the weakness or the disability in radial nerve paralysis. The most common complaint that the patient comes to us with, obviously deformity, but also weakness in grip and pinch. How that happens is because the wrist inflection gives slack to the flexor tendons of the fingers. And unless we stabilize the wrist in 15 to 20 degrees extension, the full grip power cannot be achieved. Similarly, in the pinch, the thumb needs to be stabilized. And if it is not stabilized well, the pinch will be weak. Actually, we have done this study, and there is at least 50 to 60% weakness in grip and pinch in these patients. It becomes difficult to release objects. And if we want to grasp a large size object, the fingers need to be extended fully. Nerve repair has been discussed. I won't go into details, but radial nerve is usually considered a good nerve for neurography because it is purely motor, and the distance that it needs to travel before supplying the muscles involved is relatively small. Timings also has been discussed. I won't dwell into it. Splintage, various splints are available. A simple wrist immobilizer, a beautiful costly splint like this, a dynamic cock-up splint, or something which is available at a lesser cost, which is bulky and has social stigma, makes the use of hand difficult. So a patient who's going to the office just needs to stabilize the wrist, may choose just a wrist immobilizer and nothing more than that. As a preference, dynamic splints should be preferred because they prevent contractures. They allow the opposite movement, and the opposite movement doesn't get restricted, which can happen in a static splint. So going further from what Dr. Jindal has already explained, we look at what is the deficit, the wrist extension, finger extension and thumb extension and abduction. We look at what is available, what muscles are available, and we come to a formula as to what to do. Now, a typical answer for radial nerve paralysis would be a triple transfer. Triple Jones transfer or a modified triple Jones transfer usually becomes difficult. There are at least 9 or 10 modifications of triple Jones transfer. So for understanding, I would say that let's look at what is available and what needs to be restored. So pronator teres to ECRB, some authors attach it to both, but ECRB being the central tendon gives wrist extension. This is the most important wrist extensor actually. And attaching the pronator teres to ECRB is almost consistent in any of the triple transfers which are described. Finger extension can be FCU, FCR, or FDS. Dr. Jindal has again made my job easy. FCU and FCR are synergistic transfers. FDS is non-synergistic transfer, but the excursion of FDS is closer to EDC. So some authors do prefer FDS for extension, although being the non-synergistic, it is difficult to train the patient for that. Again, one of the consistent transfers. So variation is mostly in the finger extension. Another consistent transfer is thumb extension and abduction by palmaris longus, which is attached to rerouted EPL. By rerouting the EPL from the dorsum to the radial aspect of the thumb, we are able to achieve some amount of radial abduction also. So most of the transfers that we'll read about will have these two components as consistent, and this would be the variation. This is the original Jones transfer where both FCU and FCR were used for extension of the fingers. This is considered not such a good policy because we cannot take away both the strong wrist flexors. It causes disability for the patient. But this is what original Jones transfer was described. He has described it in 2 different papers. And if you can see, FCR insertion is variable in the 2 transfers which have been described by Jones. The most consistent transfers are this. I've already said pronator teres to wrist extension, palmaris longus for EPL, and FCR for finger extension or FC for finger extension. These are the most common triple transfers that we use for tendon transfer. We can discuss the plus and minus of FCR versus FCU. I think it will be beyond the scope of this lecture if I start going into the details of that. Standard picture from Greens, I won't again dwell into it. Some authors prefer straight away going for tendon transfer, which Dr. Dhal has explained may not be the best policy, but in certain situations like large gaps, very high lesions where the recovery may take a long time, excessive scarring and old age, one may choose to do a tendon transfer straight away as the definitive treatment. Thank you.
Thank you, Dr. Vineet. Dr. Vineet, can we go to the next speaker and then we take questions at the end?
Yes, sir, sure.
Because it's now 6:20. So let us first finish the...
Dr. Ajish, I would like to invite Dr. Ajish with his brachial plexus talk. I think for the exam purpose, brachial plexus is an important short case. So let's go on to that. If we have time, we'll go for the lower limb. Otherwise, we'll finish off with the brachial plexus.
No, let us finish all the presentation.
Sure.
I think Dr. Ajit, please be quite crisp about the presentation.
Yeah.
Okay, Doctor.
Ajish, are you ready?
Dr. Ajish, can you hear us?
We can't hear you, Ajish.
Yeah, am I audible now?
Yeah.
You're audible.
Okay, thank you. Thanks to the organizers at the Delhi Orthopedic Association to invite me for this talk. I'll start off with the brachial plexus palsy assessment and strategy. So this talk is, I don't intend this to be a very high-end talk. We'll try to keep it for what the students would need to get through an exam. So focus basically on the examination and muscle charting, which I feel is the most difficult part of the brachial plexus palsy short case. So adult brachial plexus palsy, that's what we're restricting ourselves to, comes in a large variety of forms. It can be just a partial palsy to a global palsy and can even end up with a bilateral brachial plexus palsy. So, and these things can look difficult to a student, but the point here is that we need a systematic approach to this examination to get through the exam and even in real life to treat these patients. And that is strongly based on a knowledge of our anatomy of the brachial plexus as well as a proper muscle examination. The distal muscle examinations, usually we are more familiar, but examination around the shoulder and the elbow is somewhat more difficult for the PG students. So straight ahead to the anatomy, I like to take some time with the anatomy because again, as a student, I remember that the difficulty in brachial plexus palsy cases was actually revising the anatomy of the brachial plexus. And then as far as I understand, if we grasp the anatomy, the case of brachial plexus palsy is basically an application of other principles of peripheral nerve injuries. So we all know that the brachial plexus is formed from the 5 roots as the C5 to the T1 roots. And the upper 2 roots meet to form the upper trunk. The lower 2 roots meet to form the lower trunk, while the middle C7 continues as the middle trunk. So there are 3 trunks, each of which has an anterior and posterior divisions. So which means that we now have 3 anterior divisions and 3 posterior divisions, out of which 2 anterior divisions, the upper 2 anterior divisions, come together to form the lateral cord. The one remaining anterior division forms the medial cord, and all the 3 posterior divisions come together to form the posterior cord. So it's a useful thing to remember that there are 3 trunks and then there are 3 cords. Of course, there are, and each trunk has 2 divisions in between. So that makes it easier to remember the anatomy of the brachial plexus. There are 3 trunks, and then we end up in 3 cords. So from then on, it's actually pretty straightforward because after the cords, we go straight into the branches. And the first branches are coming from the root themselves, which one from the C5 root, which is the dorsal scapula, and one from C5, 6, and 7, which is the long thoracic that goes to the serratus anterior. After the root, the next branch comes in from the suprascapular, that is from the upper trunk. And the others, usually we have these acronyms to remember these for the lateral cord, LML, which is lateral pectoral, the musculocutaneous, and the lateral root of the median. For the posterior cord, we usually remember it as ultra, which is upper and lower subscapular, the thoracodorsal, the radial, and the axillary. And for the medial cord, there's actually 4 medial branches, which is the medial pectoral, the medial cutaneous nerve of the arm and the forearm, the median root of the medial, as well as the peripheral nerve, which is the ulnar nerve. So knowledge of the branches, I think students are more familiar with, but there's a more proximal ramifications that are more difficult and should be practiced often so that we are comfortable with these at the time of the exam. So going ahead, the aim of our examination, what are we trying to find out when you're doing when you have a brachial plexus case? One is the extent of the injury. Is it a partial or a complete injury? What is the level of this injury? Do we have a root level injury, or is it more distal in the trunks, division cords, or even just the branches? And maybe even try to find out if there's any change related to time. But of course, as Dr. Dhal had pointed out, in an exam, we are only given one chance to examine, so we really would not be able to get into that too much. So the extent of the injury is something that we can think of as the breadth of the injury from C5 to T1, the entire breadth of the brachial plexus, what all is injured. And well, grossly, C5 mostly goes into the shoulder. So weakness of the shoulder should, especially abduction, should signify an injury to the C5 component. Weakness of elbow flexion should signify a weakness of the C6 component, and lack of power in elbow and wrist extension should signify an elbow weakness of the C7 component. Weak finger flexion in the C8, and T1 mostly goes into the finger intrinsics. The same thing, apart from motor, when you go into the sensory examination as well, C6 mostly supplies the thumb and the index. C7, the middle three fingers overlapping, and C8 goes to the small finger. So in a dermatomal examination with C6, 7, and 8 examination should give us an idea of which components of the brachial plexus are involved. So based on this, based on the breadth of the injury or the extent of the injury, we usually classify them into multiple common patterns, which includes the upper plexus palsy, which is an injury of the C5 and C6 component. And then what is sometimes called the extended upper plexus palsy, which includes the C7 component as well. And then obviously the global palsy, which is the entire breadth, which is C5 to T1. Now there is, well, we also know that there is a lower plexus palsy, which involves the C8 and T1, but this is clinically very rare. We usually do not see cases where we have weakness of only the hand. Mostly if the hand is weak, we would have some weakness in the proximal part as well. So the isolated lower plexus palsy is a very rare situation. So the next point that we're trying to find out is the level of the injury, and that we can visualize as along where is it along the length of each brachial plexus component. And perhaps this is the most important thing that a clinician is trying to find out. So, and along the length, is it in the root level? Is it at the trunks? Is it somewhere distal? And out of which we are very interested in finding out whether this lesion is an avulsion, or maybe it's a rupture, or it's an even further distal injury. So the avulsion and rupture is something that's, again, was confusing to me as a student. So I'll just take some time here to understand the formation of each of these roots. So this is the cervical vertebra, the spinal cord, and we have out of exiting the spinal cord are the dorsal and the ventral rami. And the dorsal ramus has the dorsal root ganglion, which is sensory in nature, and the ventral ramus constitutes of the motor fibers. And as they exit the neural foramen, they also give branches to the paraspinal muscles. And that it is after these branches that it comes out of the neural foramen, and then they form the brachial plexus afterwards. So what we mean by an avulsion is also what is called a preganglionic injury. So this is the dorsal root ganglion. And if the injury is more proximal to it, it has pulled out of the spinal cord itself. That is what's called a preganglionic injury. And diagrammatically, that's what it would look like, that the neural foramen is empty, and we have the roots lying outside. And the trouble with this is it's experimental to try and put this back into the spinal cord, and the only options for treatment available would be a nerve transfer. But on the other hand, if you have a post-ganglionic injury and the rupture is actually distal to these ganglion, for example, as shown diagrammatically here, we have the nerve root coming out of the neural foramen. We find an injury here, we may still be able to graft and get some function out of this root. So what are the findings? Again, I think this is a common question that comes up in an exam is, what are the findings that suggest a preganglionic injury or an avulsion? So I think first and foremost, that can easily be picked up on an examination is the Horner's sign. And looking at the eyes, that would be a combination of meiosis, ptosis, and anophthalmos. And that comes about because the sympathetic fibers to the eye actually exit the spinal cord after they come from the hypothalamus. They exit at the C8 and T1 root level, and through these roots, and then they enter the sympathetic ganglia at this level, and then they are actually spread to the head along with the sympathetic fibers, which travel along the internal carotid and the external carotid arteries. So any injury in the C8 and T1 root avulsion actually breaks these fibers, and that would mean that the sympathetic input to the eye is lost, and that's what causes the Horner syndrome. And another finding would be an absence of Tinnell sign in the supraclavicular region. And from early presentations, we understand that the Tinnell sign is a sign of a nerve injury, and it actually localizes to wherever the nerve is compressed or injured. So if you don't find a Tinnell sign in the supraclavicular region, that can usually mean that the injury is an avulsion, because then the proximal end is actually within the spinal canal. And then there are other contributory evidence, like the head can be shifted away from the site of injury. There can be atrophy of the paraspinal muscles and a winging of the scapula, as we see on the left side of this patient here. And a very common finding in all preganglionic and avulsion injuries is severe neuralgic pain that these patients have, which is a deafferentation pain, is often considered to be thalamic in origin, and it's very difficult to manage. So a severe pain in the upper limb is also another sign that these patients can have avulsion injuries. So an associated phrenic nerve palsy. So the Horner sign actually shows us that there might be an avulsion of the lower roots, while the phrenic palsy, which comes from the C234 level, actually tells us that there might be an avulsion of the upper roots. So I'll skip that, because as I said, in a single examination, we'd probably not be able to find out, but a progress of Tinnell, if we find any, is a sign that there might be some recovery. In the history, the patient may offer that they have had complete weakness, with some of which has recovered in the time being, and that is a sign that there might be some recovery, and should definitely be noted while we're taking this case. So on examination, so from the front, what can you find? So here is a patient who has a scar in the clavicular region, and the other findings to find as well. With the posture of the patient, is there a sag in the shoulder levels, Horner sign which would be visible, and a characteristic sign of an upper plexus or a global palsy would be the sulcus sign. And the sulcus sign means that this area appears empty, and there's a sulcus which develops between the acromion and the humeral head, because the weight of the limb is now pulling the humeral head downwards, and there is no tone of the deltoid. And even the bulk of the deltoid would be decreased because of muscle wasting, which makes this sulcus appear. That's a very classical sign that there is a paralysis of the shoulder abductors. So these would be obvious from the front, and from the back, again, the level of the shoulders and the atrophy of the muscles, including the parascanal muscles and even scapular winging, may actually be available, maybe observable even at rest. So in a global palsy with avulsion of the roots, again, as I said, there can be a sagging on the involved side. So this patient, we have a sagging on the left side, because actually the trapezius is also weak, which means that the shoulder level droops. And from the back, we would be able to find the wasting of the paraspinal muscles. And since the paraspinal muscles on one side are not acting, the head is automatically pulled away to the non-injured side by the paraspinal muscles on that side. So in this patient, when we get this appearance straight away suggests to us that the injury should be somewhere here. It should be a preganglionic injury. So, and coming to feel or palpation, I think for peripheral nerve injuries, the most important part would be checking of sensation, and which would be the easiest way to determine the extent of this injury. So this I've already covered. So checking the dermatomes, coming to understand which parts sensation is not available, gives us straight away an idea of which parts of the brachial plexus are involved. And Tinnell sign, we would have to find the Tinnell sign from the supraclavicular region, even distally all the way up to the elbow, to at least to gain an understanding of which level the injury is, depending upon the situation. So I think the next most difficult thing for all students was always muscle charting, and a systematic approach is needed for that. And this is something that may always been called the walk the plexus examination, which is basically nothing much except that we start at one corner, which is the most proximal corner, and try to make our way downwards along the brachial plexus. And with this would one thing, it ensures that we don't miss anything. The second thing, it ensures that wherever we find abnormalities, we know that from that level onwards is where the injury is going to be. So Before we actually examine any of the muscles of the brachial plexus itself, an important muscle to examine will be the trapezius supplied by the spinal accessory, because it is a common donor for reconstructions of the brachial plexus, and it might even be used for a tendon transfer later. So we need to check the trapezius, which is usually checked by shrugging of the shoulders, and we appear and giving resistance the level of the acromion to make sure that the trapezius is acting and to try and grade trapezius power. So, and then moving on, so as I said, the first branch is the one, the dorsal scapula that comes out of the C5 root and which supplies the rhomboids. They're usually checked by asking the patients to brace their chest while we palpate for the medial border of the scapula. And if the rhomboids are acting, the medial border of the scapula should move towards the vertebral line. That is, it should retract. It should move towards the vertebral line. And it is this movement that we're trying to feel. The rhomboids can't be palpated by themselves because they are under the trapezius. So moving on, the next root branch should be the long thoracic, and that's actually pretty straightforward. We just check for retraction of the scapula. The next thing to check for is protraction, because the serratus anterior is a protractor of the scapula, and we check it by asking the patient to push against a wall and look for scapular winging. But the trouble is, most patients with brachial plexus palsy would not be able to stabilize their upper limbs to actually push against a wall. And then there are two methods to actually go for it. Which is just to try and move the shoulder forwards in a standing position and try to feel whether the medial border of the scapula is now moving forward as well. Or another method would be to support the arm at the level of the elbow and then try to see if the patient is able to move the shoulder forward. So like you can see here, this is a normal individual. So they're able to move the shoulder from this position forwards, and we can palpate for the medial border of the scapula. And if that also moves laterally, we know that the serratus anterior must be working. The importance here is that if the serratus anterior is working, but the rest of the upper arm is not, then we know that at least some part of the roots must be intact, and the injury must be distal to this, which would raise hopes that we should be able to find a root later for repair. So then the next branch, as we said, comes from the upper trunk, which is the suprascapular, which supplies the supraspinatus and infraspinatus. So the supraspinatus, as we see, is an initiator of abduction. And this is not how we usually check it. We check it from an adducted position and try to see if the patient is able to initiate abduction from a completely adducted position. But a more easier muscle to check usually is infraspinatus, which is an external rotator, which you can check by external rotating with the arms fixed by the side. Moving on, trying to complete all the C5 level muscles here, we would move on to the deltoid. And the deltoid is an abductor, which, and usually to check, we start from a position of 90-degree abduction and ask the patient to move, abduct from there. And this, we can actually delineate the anterior and posterior parts by checking this in some flexion and some extension as well. Like we can see the posterior deltoid contracting strongly in this picture. And on to the next muscle, which would be the latissimus dorsi, and which is an adductor of the shoulder. And we can easily see this, the contour of the muscle in the posterior axillary fold. But it is most easily checked actually by extension in adduction. There are no other muscles which do that. And so if you ask the patient to extend in adduction while feeling at the posterior axillary fold, you should be able to feel the latissimus dorsi contracting. Then we are left with the subscapularis, which is easily checked with a belly press or an internal rotation check test. Once we finish off all of those, we come to the pectoralis major, which has two separate heads, the clavicle and the sternocostal. And we can check them separately actually by, one is an adduction in the plane of the shoulder, which is towards the opposite shoulder. And another is adducting towards the opposite hip or the opposite pocket. And when you're in the plane of the shoulder, we are actually checking for the clavicular part, which is more horizontal. And when you're going towards the opposite hip, we are checking for the sternocostal part, which is more oblique. And we can feel these parts separately to ensure that they are contracting. So finally, we are on to the musculocutaneous, an important branch of the lateral cord. The important ones would obviously the biceps, which is easily palpable, is easily visible. But often it is important to note and feel for this muscle, because the patient might be able to flex the elbow, but there is no biceps which is acting in this case. The biceps is totally lax. And why is that? That is because they are compensating by using the brachial radialis or even the flexor pronator mass. So it's important to feel for the muscle always when we check for them, and especially in brachial plexus and other peripheral nerve injuries, there are a lot of trick movements that patients learn over time and which we should be aware of and be able to deal with them. So peripheral nerve examination, I think they have all been covered. We really need not go into that. Imaging for these cases, when we come to the discussion of this case, X-rays are really only for associated injuries, and MRI, the only importance of the MRI is that it might tell you that there is an avulsion injury if it is done at least 3 weeks or so after the injury when a pseudomeningeal forms. Electrodiagnostic studies, again, the importance is only to find out whether there is an avulsion or a rupture. It takes a very good neurologist to actually tell us whether there are nerve potentials which are recorded in the area which is clinically anesthetic. And when you find that, that actually means that a dorsal root ganglion is intact and the injury should be proximal to that, which makes it automatically by definition that is a preganglionic injury. And then of course, in situations when you have mixed patterns of recovery, you can have information from the muscles by with electrodiagnostic studies, which give us some more early assessment of recovery as well. So management, I think currently the opinion is pretty clear that the management is a primary nerve reconstruction. It is the treatment of choice for all non-recovering palsies, and secondary reconstruction should be kept only for those who have actually failed primary reconstruction or they have a delayed presentation. So nerve reconstruction, just to give you a quick understanding, it's now between the choice is usually between a graft or a nerve transfer. Nerve grafting is simply exploring the brachial plexus and grafting the gap in the plexus from connecting the roots to their distal stumps. That's as for any other peripheral nerve. A nerve transfer is actually using an uninjured nerve and transfer it to a more distal target. So, well, graft is, while it is anatomic, it tries to reconstruct the normal anatomy. A transfer has its advantages that it is an uninjured donor that is used and usually gives faster recovery because we are closer to the muscle that we are trying to renovate, and also because the target is more focused. We're trying to renovate just one muscle rather than a whole entire segment of the nerve. So for an upper plexus palsy, in a patient when we find with a lack of elbow flexion and a lack of shoulder abduction, or at least lack of shoulder stability, what we need to provide are these two movements. And the strategy would be, the primary choice for these patients now would be what's called an Oberlon's transfer, which is a transfer of a part of the ulnar or the median fascicle to the biceps and or the brachialis, depending on the status of the ulnar and the median nerves. And we can go ahead, if tendons are available, especially the pectoralis major or the latissimus dorsi are available, we can go ahead with these tendon transfers. And the Steinler flexoplasty, which is a proximal shift of the common flexor origin, that can be used if we already have an elbow flexion power of at least of grade 2. For a completely paralyzed elbow, a Steinler flexoplasty is unlikely to give any functional results.
37.5.
So a free functioning muscle transfer is then the last choice if none of these are possible. For shoulder abduction, again, a nerve transfer, which is spinal accessory to suprascapular, or a trapezius transfer or a shoulder orthodesis as secondary reconstruction options. Just some quick pictures that show the nerve transfer, the spinal accessory to the suprascapular. And this is how an Oberlon's transfer is carried out by the ulnar nerve and the median nerve. We take a fascicle each, they're connected to the biceps branch. This is actually the musculocutaneous nerve, biceps branch or the brachialis branch. And that should give us a quick and good reinnervation. And they can give good results regarding elbow flexion as well as shoulder abduction. But the trouble with global palsies would be that now we have an added problem of the hand being weak with an asensate hand. And now we have less donors. The median and ulnar are also paralyzed. We cannot use them now for elbow flexion. And these are more difficult choices, more difficult things to treat. And the only option for these are basically an early exploration and go ahead with nerve transfers. You can, if you find any of the roots like the C5, 6, or 7, they can be used for grafting, or else we can use do a transfer by using the spinal accessory, the phrenic, the intercostal to 2, 3, 4, and 5. They are the common ones used to transfer to the brachial plexus, or even what is now up and coming is a contralateral C7 root. So the contralateral C7 root is dissected, then it's brought around to the opposite side, and then is connected to the any of the donors. Usually is connected to the hand. And hypoglossal was one of the earlier ones, is currently out of fashion. So and when none of this is possible, the only way we could actually get any movement for a completely paralyzed upper limb would be to harvest the gracilis muscle along with its nerve and vessel branches, which is the nerve supply comes from the anterior division of the obturator nerve, and vessel usually from the medial circumflex femoral. We harvest the entire muscle, repair the nerve, anastomose the vessels to make sure the muscle stays viable, and that can give some elbow flexion if you connect it to the biceps tendon, and can even be sometimes used to get some hand function as well. Thank you. I'll stop this at that. Should we go ahead with the next one?
Yeah, Dr. Ajish, I have taken extra time.
Sure.
So you can continue with your lecture, but I will exit at 6:50 because I have another webinar to conduct by Dr. Dror Pelle. So in my absence, Dr. Shamsul Huda and Dr. Ravi will take over. But try to do it everything in.
I'll try and do it in 5 to 10 minutes. Sure.
So I will hand over to Dr. Ravi, okay, and Dr. Shamsul. Okay.
Okay, so the next one is actually on nerve injuries of the lower limb. Sorry. Okay, so these are, I think, somewhat more uncommon cases to find in an exam. Is again the nerve injury of the lower limb. So I just made a quick presentation. I'll try to run through it. And again, I felt the difficulty as a student was that we are not really as familiar with anatomy of the lower limb nerves as we are actually with the upper extremity nerves. We have heard more, we have learned more about the radial, median, and ulnar than we actually ever read about the peroneal and others. So, well, the lower limb nerve supply starts from the lumbosacral plexus. The only important thing to realize is that femoral nerve comes from the L234 roots of the lumbar plexus, and the obturator from the same, but the anterior divisions of these of this plexus. And the sacral plexus is what eventually forms the sciatic nerve. The common peroneal comes from the posterior divisions, the tibial component comes from the anterior divisions, and then there are also the superior gluteal and the inferior gluteal nerves that come out of the sacral plexus. Just a quick reminder, the femoral nerve is what motors hip flexion by the iliopsoas and knee extension from by the quadriceps femoris with root value of L234, and sensation mostly the entire lower limb, anteromedial aspect of the entire lower limb, the thigh, leg, and even the medial foot through the saphenous nerve. So, and then the obturator, not a commonly injured one, but it's possible, and it is a nerve of the adductor compartment of the thigh, and it supplies the adductors. The sciatic obviously is, I think, a more common injury, and after it exits the greater sciatic notch, it supplies the knee flexors, which are the hamstrings, and then actually all of the muscles of the ankle and the foot by its common peroneal and the tibial component. So the tibial component is what innervates the triceps suri, the gastrocnemius, and the soleus, and then on to the tibialis posterior and the finger flexors and the intrinsics, etc. The important part here to realize is that the tibial component is what provides sensation to most of the plantar surface of the foot by the medial plantar nerve. And the common peroneal, again, I think the commonest case to find in an exam would be a common peroneal palsy and a foot drop. And the common peroneal, after it winds around the fibular neck, usually divides into the two superficial and deep peroneal nerves. The superficial is the nerve of the peroneal compartment, supplying the peroneus longus and brevis, and the deep peroneal supplies the ankle and toe extensors. So what are the causes of lower limb nerve injury? Like for the upper limb, they are usually closer open injuries or crush injuries of the limb. But unlike the upper limb, they are very commonly iatrogenic, from injection injury to the sciatic nerve, and to even procedural injuries that happen during hip replacement, herniatomy, and other obstetric and pelvic procedures. And then common to other nerve injuries, they can have sharp cut, gunshot, and tumors. But the important here is that the lower extremity nerve injuries are actually more common in military practice than there are in civilian practice, because somehow projectile and other injuries tend to cause more injury to these. So coming to the iatrogenic injuries, it's important to understand that a femoral nerve can be injured in the total hip replacement, but it's more commonly injured during hernia surgery and obstetric procedures. The sciatic nerve, again, during hip replacement or an acetabulum fracture fixation, but also during hip arthroscopy. And even if you apply, there's a predilection for sciatic nerve injury if you apply pre-op traction before hip fracture fixation. and others of the common peroneal nerve, which most commonly is injured when we are correcting the valgus and flexion deformity during a knee replacement. And rarely we can also have saphenous or sural nerve injury from varicose vein surgery. So quick run through for the cases. The important part of this history, since most of these are either traumatic or they are coming from iatrogenic causes, is to take a proper history of the injury as well as what surgery and how these were performed. And if the patient is able to give you any history regarding recovery, that has to be recorded as well. And the examination, again, to match that would be to find whether to delineate the scars of the prior injury or the surgery. And common to common to other peripheral nerve injuries, muscular atrophy, trophic ulcers, especially in the foot, and then go on to muscle charting. In presentation, what we would see is that the femoral nerve injuries would present with weak hip flexion and knee extension. Sciatic nerve injuries at the thigh level, which basically means that both the components are involved, should present with a weakness of knee flexion and complete paralysis at the ankle and foot. And if it's isolated common peroneal, that should be a paralysis of the ankle and toe dorsiflexors and foot eversion if the superficial peroneal part is also involved. So I think a very common question in examinations is, why is the common peroneal more commonly injured than the tibial component? It's not just more commonly injured, it's when both components are injured, it's often more severely affected. And even after a repair, if you repair both the common peroneal and tibial component in a sciatic nerve injury, it usually has poor recovery post-repair as well. And the classical reasons which have been listed out and which are sometimes asked in the exam would be that one, it is relatively more fixed because when it exits a greater sciatic notch and then it winds down the fibula head, it's fixed at these points. So it actually allows only a mobility of about half a centimeter. It's more superficial in the thigh, so any external trauma is more likely to injure the common peroneal component. The fascicles in the common peroneal nerve are more tightly packed. There is less connective tissue to absorb any compression or any other injury, so they're another reason for it to be more commonly injured. And then what is also said is large fascicle size. The fascicular groups of the common peroneal are also larger, which means that they are also more prone to compression by Laplace's law, which that would mean that with a larger sphere, size sphere, a greater pressure is actually required to maintain the intraluminal pressure. So these are the classical ones that have been described for common peroneal, but then there are others which have been also been postulated, that the common peroneal actually innervates long thin extensor muscles, and that by multiple branches, and that need coordinated contraction for a functional movement. In contrast, the tibial, mainly when it innervates the gastrosoleus, it's a large muscle, and even if we get some contraction, that should give us a functional result post repair. And then also that the anterior compartment is tighter. So in the situation of a compartment syndrome, we can have the situation where the muscle as well as the nerve is more likely to get damaged from a compartment syndrome. So moving ahead, quickly running through the strategy, I think for all open injuries, whenever they present to us, the treatment that we should offer should be an immediate and early exploration. Most of these open injuries would probably be neurotematic injuries, and there is no way that they are going to recover spontaneously. So in exam, if you find an open injury, I think it would be safer to straight away offer immediate and early exploration and find the nerve. Obviously, the plan would be to repair or graft it. If it's a closed injury in the lower limb, especially the sciatic, which comes after surgery, most authors would recommend that we can wait at least 4 months and even up to 6 months to see if there is any recovery. If there's no recovery within this time period, we should proceed to nerve exploration that would decompress or repair or graft as would be needed. So so this would be an open injury presented late. So we would end up with exploring it. They usually need a very large incision because the muscle bulks are larger. You need a large incision to find the sciatic nerve. And this was actually, we were able to repair it end to end. But then secondary reconstruction. So again, like I think, again, common with all peripheral nerve injuries, that is indicated for a delayed presentation or poor recovery post-nerve reconstruction. And an interesting, I think, rule to remember for post-catches is what's called McKinnon's rule of 18. And the rationale is pretty simple, that it's already been described by Dr. Dull. The motor end plates usually degenerate by 1 year or by 1.5 years, that is by 18 months. So whatever repair we do should reach these motor end plates. The nerve fibers should reach these motor end plates within that time period from injury. And so that helps us realize whether we should go for a nerve primary reconstruction or should we straight away go for a secondary reconstruction. Because if the time since injury in months and the distance to target in inches, which basically we are calculating that we are having a nerve growth potential of about 1 inch every month. So that should total up to less than 18. If it is already too much delayed, that would mean that there will be really no point in going ahead with a nerve reconstruction, because you would not expect to get any motor function. But for sensory reasons, you may still go ahead, especially for the tibial component, you might still go ahead and explore and try to repair it and get some sensation in the plantar foot. And the goal for all of these secondary reconstruction would achieve a painless, stable weight-bearing limb and as much plantar protective sensation as possible. So I'm not going into details of secondary reconstruction of all the nerves, but just to the common peroneal, where the deficit is an ankle and toe dorsiflexion. And you may have a weakness of foot eversion. If it is an isolated deep peroneal injury, the foot eversion may be spared because the peroneal would be spared. And the donors available then would be usually the most common one is the tibialis posterior. The FDL is sometimes used along with the tibialis posterior. And as we said, if the superficial peroneal nerve is not injured, the peroneus longus is also an available donor. And I think by far the most common one used is a tibialis posterior transfer to the dorsum of the foot, and which could be through an intraosseous membrane route via the intraosseous membrane at the distal leg level, or it could be circumtibial and subcutaneous around the medial border of the tibia. And then there's a choice of insertion whether to the either middle or lateral cuneiform, or correspondingly the second and third metatarsal, or to even tendinous insertion to the EHL and the EDL. Well, the intraosseous route is usually credited to Barr, but historically, Cordivilla, Putti, and all the first tendon transfers ever performed were through the intraosseous route. And Ober later on came up with the circumtibial. This is sometimes asked in exam, where you expect to hear the answer Ober for circumtibial and Barr for the intraosseous route. And as far as insertion, as this diagram shows, is planning the tendon has been delivered anteriorly and then is taken around under the extensor retinaculum, and this to be inserted around the second or third metatarsal basis. But you can also have the insertion to the EHL and EDL, which is trying to balance both inversion and eversion, and it's commonly used in leprosy. It was described by Srinivasan, often called the Srinivasan transfer, and is commonly used in leprosy patients. So, but before we go in for surgery, like all peripheral nerve injuries, the important part would be to maintain passive range of motion while we're waiting for recovery. We should ensure that we have a passive range of dorsiflexion of at least 10 degrees, use an ankle foot orthosis to prevent an equinus contracture, and to strengthen the donors, which will be the posterior tibialis posterior in this case, which strengthening the exercises does not just strengthen the muscle belly, it also helps the patient to identify this muscle later for when we try to train these patients after during rehabilitation and during physiotherapy. They are able to isolate these muscles and contract them better if you have already taught them that preoperatively. So some pictures of a tibialis posterior transfer, they're courtesy of Dr. Dhull and team from their paper on early tendon transfers. So this is a tibialis posterior that has been disinserted and been pulled into the distal leg. And there the intraosseous membrane has been exposed between and the level of the distal leg. And the tendon is then delivered to the anterior compartment. It is then tunneled under the extensor retinaculum, and you can anchor it onto the bone with either an interference screw, or now stronger anchors are now available, or even a pull-out suture at the base of the foot. So, and usually after such a transfer, for all lower limb tendon transfers, it's preferable to immobilize the ankle and the foot for 6 weeks, and then start rehabilitation in the form of ankle range of motion and protected weight bearing. So I'll stop at that. Thank you.
Thank you, Dr. Ajish.
Thank you.
There are a few questions for you, Dr. Ajish.
Okay.
Yeah, actually, I will be quick just because of the time.
Right.
C5 is assessed by shoulder abduction or elbow flexion. I mean, PG is asking which is better, or what is the single muscle testing for C5 actually?
C5 would be shoulder abduction, because elbow flexion is contributed both by C5 and C6, with C6 being more dominant. So shoulder abduction, on the other hand, is more dominantly supplied by C5. If you look at shoulder abduction is brought about by supraspinatus and the deltoid. So the supraspinatus is actually purely C5 because it comes from the almost purely C5 because when it comes from the upper trunk. So for that reason, weakness of shoulder abduction would more strongly signify a C5 lesion.
Okay, thank you. And then the next question for you. By that time, can you stop sharing the screen?
Oh, sure. Yes.
The next question is, for brachial plexus palsy, can we do distal muscle transfers or neurotization? Which is better?
For incomplete palsies, yes, you would be able to do if some donors are available, we would be able to do a distal muscle transfer. But as far as which is better is concerned, as long as the patient is presented to you on time, and neurotization definitely would be better. In the sense that I think this has already been covered by Dr. Dhalsar as well,
yeah.
that gives more independent movement when the muscles are re-innervated as compared to doing a tendon transfer. And then we also have to remember, when you're doing a tendon transfer, we've actually also decreased some power in that aspect where the tendon has been used. So if you're using FCU for some tendon transfer, we actually decrease some power in this flexion as well. So as long as you're able to not use FCU and give some power by neurotization, that will certainly be better. But this is all within the caveat that the patient should present early enough that the neurotization should be possible. If that is not possible, then obviously we'd have to go ahead with a tendon transfer.
Thank you. Next question for you also. How to differentiate between foot drop due to long-standing CPN palsy with joint contractures and stiffness, and an equinus deformity due to other neuromuscular condition?
Okay, so one of the, I think there are a lot of different things to do, but one very straightforward test would be sensation. Because if it is a CPN palsy, we should expect loss of sensation on the dorsum of the foot. And if it's other joint and other contractures, we really don't expect that there should be any loss of sensation along the dorsum of the foot or the CPN area. Yes, we can have a confusion because there can be an equinus contracture with a common peroneal injury, and we would also have a problem with if there's a joint contracture that can also present superficially, it can look the same. But when it is a joint problem, when it is a other neuromuscular problem, we don't expect a loss of sensation. The second point would be if we can actually demonstrate that there is eversion present, that could actually mean that only the superficial peroneal nerve part is intact, and that could also help us differentiate between these. If there is some eversion present, that could actually mean that the CPN may be intact, and it can more likely that we have a joint contracture problem than a nerve problem.
Okay. And another question for you from another postgraduate. When should we consider for the ankle arthrodesis in case of foot drop due to CPN palsy?
I think ankle arthrodesis should be one of the last options for a CPN palsy, because we would have proper donors available. But in those situations, I guess when there's a long-standing contracture, there is a very tight Achilles tendon, there might be bony changes on an X-ray, there can be a collapse of the tarsus. In those cases, and these are actually more common in leprotic patients. They may have some improper sensation, they can have CPN palsy, they can have some kind of a Charcot arthropathy of the ankle and the subtalar region. So those patients would probably be indications for ankle arthrodesis. But otherwise, for what is an isolated CPN palsy, to go ahead with an ankle arthrodesis should be the last option.
Okay, thank you. And another question is for Dhalsar. Sir, one of the postgraduate is asking, sir, could you explain between complete and incomplete nerve injuries, how we should assess clinically?
Yes, I think it's a very good question. Because as I said, if the patient is presenting to us months later, then the problem occurs that we have to decipher between, is it a recovering lesion or it was an incomplete lesion to start with? So one of the telltale signs here would be that if you find that, supposing we take the instance of the radial nerve case that we had taken, in that patient, if we at 6 months find that the proximal musculature, that means the brachial radialis has started working, though it may have been a little weak, and maybe a little wrist extension is also coming back. This is a case in which recovery is occurring. On the other hand, if we find that one of the distal muscles has been spared, whereas the proximal muscle is not yet innervated. This means that, say, take for instance, his EPL is working, but the extensor digitorum communis is not working, the wrist extensor is not working, then this is clear-cut case of an incomplete paralysis to start with. I think this is how patients can be deciphered. At times it can be difficult, but this is in a nutshell how it can be done.
Thank you, sir. Thank you, sir. Now there are no further questions from postgraduates. Sharad sir, is there any other question within the panel?
Dr. Ravi, can I ask one question?
Yeah, Dr. Vineet, please go ahead.
I think my question to Dr. Dhal again. Sir, most of the time when we are having the post-operative radial nerve injury, what is the ideal time for tendon transfer? Second, does the timing of tendon transfer is differing in relation to the mode of injury, whether it's a clear-cut injury or it is compression injury? Thank you.
I think this is another very, very tricky question. And if it is a post-operative documented radial nerve paralysis, one needs to be very careful, because you must remember that the person who has done the surgery is a qualified orthopedic surgeon. He must have taken due care to protect the nerve. But in spite of that, if the nerve has become paralyzed and this patient has shifted allegiance from the previous surgeon to you, the best thing would be, do not be in a hurry to explore. It is always better to wait and to take this injury as a sort of a injury which has been caused by handling of the nerve or retraction at the time of surgery. So it would be better that you wait for a reasonable period of time, and I would say at least about 4 to 5 months you must wait. When EMG in the Brachial Radialis at the end of 4 or 5 months, again this will be guided by the distance to be traveled. But if even at that time there is no recovery, then you should first explore the nerve. Because at time, as Dr. Dabas showed one case, there have been some cases where we found that the nerve has been it's been compressed by the plate. So probably the surgeon did not realize that while he was putting the plate, the nerve came under the plate and it got compressed. So in these cases, you can extract the nerve, you can resect the damaged segment, you can graft. And tendon transfer should be left as the last procedure. If you find that the lesion is not repairable on exploration, you can always proceed with the tendon transfer, preferably in a different sitting. We should not try to do too many things in one sitting. You can always take the patient into confidence, tell him right in the beginning, I'll explore the nerve. If it is not repairable, I'll do a tendon transfer later on. I would just like to add something here, which is a little recent, the concept of an early tendon transfer. If you are waiting, expecting the nerve to recover, and the patient needs to get back to work early, then instead of giving him a cock-up splint for a very long time, these days, Burkhalter has recommended that you do a single tendon transfer, taking the pronator teres and transferring it to extensor carpi radialis brevis, and do not proceed with the remaining 2 tendon transfers. This way you will be restoring the wrist dorsiflexion very early, and these patients can get back to work because their grip strength increases phenomenally simply by the ability to place the wrist in dorsiflexion. So this can be done just while we are waiting for recovery to occur. And if recovery occurs, then you will not need the remaining 2 transfers. But if there is no recovery, you can proceed with tendon transfers to restore digital and thumb extension.
Thank you, sir. Sir, there is one question from Dr.
Thank you very much.
Hitesh, sir, please.
No, it was the same question. I was asking about internal splintage only. Sir has answered it.
Okay.
Can I ask Dr. Ajish?
Yes, sir.
Dr. Ajish, what we consider is in the lower limbs, the nerve recovery after repair is not as good as in the upper limbs. If we have a, say, a neuratomosis injury of common peroneal nerve or sciatic nerve, do you think we should go for a repair, wait for a period, and then whether recovery occurs or not, or we go so straight for tendon transfers in these cases?
So again, still say that the primary choice would still be a nerve repair, especially if it is a sciatic thigh level injury, because tendon transfer options for these sort of injuries are very limited. Tendon transfers for knee flexion, hardly any that usually work. And for a thigh level sciatic injury, you would expect that the entire ankle and the foot would be paralytic. So a secondary reconstruction basically can only be either bracing or ankle arthrodesis for these patients. So for that level injury, certainly the idea would be to go ahead with a nerve repair. And later, maybe depending on the sort of recovery that we have, we can later go in for a tendon transfer as well. And I think the largest series on lower limb nerve extremity injuries, and that is very clearly shown that for these level of injuries, that's a Louisiana State University series, and that usually what we find is that the tibial component after repair does recover to a certain extent. And if we actually manage to get good recovery in the post-tibialis posterior or something, we could later use that for some balancing procedure in the foot, rather than go ahead with an arthrodesis for a thigh level sciatic injury. But when you go distally, a common peroneal, as you said, a common peroneal injury at the fibular neck or distal usually has poorer prognosis than others, but I would still like to repair it first. Like Dr. Dhal said, take the patient to conference, tell him that maybe later we would have to go ahead with a tendon transfer. But to try and do them together has also been tried again. While we were PGs with Dr. Dhal, we did early tendon transfers for common peroneal nerve injuries as well. And in our sort of settings, when we have patients who want to get back to activity, to get back to work early, that is probably a good option. But for a thigh level sciatic injury, definitely the nerve repair. For a leg and distal common peroneal injury, certainly the nerve repair plus minus tendon transfer.
Thank you, Dr. Arish. So
I think I would just like to add that when we are dealing with a sciatic nerve injury, we should not forget the sensory loss on the sole.
Yes, sir.
So nerve repair for a sciatic nerve injury is a definite yes, because we want a sensate sole. We cannot go ahead with this tendon transfer with leaving the sole asensate.
Yes, sir.
thank you, Dr. Vineet. So to end with, we are really thankful for each faculty member so that as they have spared their valuable time for us. And in the end, I would like to invite Dr. Sharad and Dr. Hitesh for their vote of thanks, please. Sharad sir, please.
Thank you, Dr. Ravi. My thanks to the learned faculty comprised by Professor Dhal, Professor Kotwal, Dr. Pankaj, Dr. Vineet, and Dr. Ajish for excellent and exhaustive coverage of the complex subject of peripheral nerve injuries. I think it's a great learning for all of us. My special thanks to Dr. Manish, Dr. Shamshal Huda, and Dr. Ashok Shyam from Ortho TV who organized these webinars. And my thanks to the sponsors of the program, Guidance Catalyze as well. Thank you.
Hitesh sir.
Yeah, I on behalf of Daily Orthopedics Association is obliged that my respected teachers had come to teach their PG students. And it was really a noble cause, and I think it's a boon for the postgraduates. This lockdown is a boon for postgraduate students that they can hear to their favorite teachers. Thank you everyone.
Thanks, sir. And in the last, I would like to just, Dr. Shamshul, can you share the last slide and we can end with that?
Yeah, please, I'm doing.
This is just for our sponsors, just guide us.
Yeah, I'd like to thanks on behalf of Ortho TV, Ortho Worlds, and DOA, the Zydus Kedla people for this academic grant, the makers of Neuropraxia. They have given a district education grant for us. Thanking again to the makers of Zydus Kedla and Neuropraxia.
Thanks, Dr. Shamshul. So, Dr. Shamshul, can we end now?
Yeah, please. I'm just ending the live stream.
Thank you everyone. Bye.
Thank
Good
you.
day.
Thank you, Dr. Vineet. Thank you, sir. Thank you, everyone.
Thank you.